ಹೊಸ ಬರ್ತಿಲ್ಲ. ಒಂದು ಮೈಕ್ರೋಫೋನ್ ಇದನ್ನ ಕ್ಲೋಸ್ ಇದನ್ನ ಕಾಪಿ ಮಾಡಿ VID ಕಾಪಿ ಮಾಡಿ ಮಿನಿಮೈಸ್ ಈ ಕಾಪಿ ಮಾಡಿ ಪೇಸ್ಟ್ ಮಾಡಿ ಇದನ್ನ ಓಪನ್ ಮಾಡಿ ಇದನ್ನ ವೆಬಿನಾರ್ ಪ್ರೆಸೆಂಟ್ ಮಾಡೋರಿ. ಅಲ್ಲಿ ಶೇರ್ ಮಾಡಿ ಟ್ರೈ ಮಾಡಿ ಶೇರ್ ಅಲ್ಲಿ ಬರ್ತಾರೆ. ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಸರ್.
ಗುಡ್ ಮಾರ್ನಿಂಗ್. ಗುಡ್ ಮಾರ್ನಿಂಗ್.
ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಸರ್. ಶೇರ್ ಮಾಡಿ ಇದು ಅಲ್ಲಾಗಲಿ ರನ್ನಾಗಲಿ ಪ್ಲೇ ಮಾಡಿ. ಇದಾದ್ಮೇಲೆ PPT ಸ್ಲೈಡ್ ಶೋ ಬೇಕು. ಎಲ್ಲ ಇದೆ ಬೆಸ್ಟ್ ಇದೆ. ಒಂದು ಸ್ಲೈಡ್ ಸ್ಲೈಡ್ ಶೋ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ.
ಮೇಡಮ್ ಇದು ವಿಡಿಯೋದು ಸೌಂಡ್ ಬರ್ತಾ ಇಲ್ಲ. ಸೌಂಡ್ ಇದೆಯಾ? ರಂಜಿತ್, ಇದು ನೀವು ವಿಡಿಯೋ ಆನ್ ಮಾಡಬೇಕಾದ್ರೆ ಆ ಕೆಳಗಡೆ ಲೆಫ್ಟ್ ಹ್ಯಾಂಡ್ ಕಾರ್ನರ್ ಅಲ್ಲಿ ಬಾಟಮ್ ಅಲ್ಲಿ ಶೇರ್ ಕಂಪ್ಯೂಟರ್ ಸೌಂಡ್ ಅಂತ ಇರ್ತಲ್ಲ, ಅದು ಮರಿದಲ್ಲೇ ಮಾಡಿ. ಅವಾಗ ಅದ್ರಲ್ಲಿ ಮ್ಯೂಸಿಕ್ ಏನಾದ್ರು ಇದ್ರೆ ಆ ವಿಡಿಯೋದಲ್ಲಿ ಬರುತ್ತೆ.
ಓಕೆ ಸರ್.
ಅದೇ ವಾಲ್ಯೂಮ್ ಅದೇ
ಸರ್ ಕೇಳಿಸ್ತಿದೆಯಾ ಸರ್?
ಕೂತ್ಕೊಳ್ಳಿ, ನೀವು ಯಾರು ಲಾಗಿನ್ ಆಗ್ತೀರಿ, ಕೂತ್ಕೊಳ್ಳಿ, ನಿಮ್ಮ ಚಾನ್ಸ್ ಬಂದಾಗ ಐ ವಿಲ್ ಗಿವ್ ದಿಸ್ and you can speak. Don't keep the Paris voice case. Good morning, Nachiket sir.
Good morning, madam.
Good morning, sir.
Good morning, madam. Am I audible, madam?
Yes, yeah, sure.
Okay, okay. I'll just, I think later we can check out, no, ma'am, whether the video is working. Shall I just check once?
Yes, sir. The 2 minutes, sir. Just we are playing on video. After that, you can check, sir.
Okay, thank you, madam. Thank you.
Yes, sir. Audio ಬರ್ತಿಲ್ಲ. Inaugural ಪರವಾಗಿಲ್ಲ, ವಿಡಿಯೋ ಪರವಾಗಿಲ್ಲ, ಬಂದು ಪರವಾಗಿಲ್ಲ, ಬಜೆಟ್ ಪರವಾಗಿಲ್ಲ. ಇದು inaugural ಫಂಕ್ಷನ್ ಮಾಡಿಬಿಡಿ, ಕಾಯ್ತಾ ಇದ್ದಾರೆ ಮಂಜುನಾ ಸರ್. ವಿಡಿಯೋ ಅವಳು ಮಾಡಿಬಿಡಿ. ಹಾಂ, ಸ್ಪೆಷಲ್ ಮೇಲ್ಗಡೆ ಫಸ್ಟ್ ಪ್ಲೇಟ್. ಹಾಂ, ಇಲ್ಲಿ ಕ್ಯಾಂಪ ಇರಬೇಕು ಒಂದು ಸೈಡಲ್ಲಿ. ಅದೇ ಸ್ಕ್ರೀನ್ ಶಾಟ್ ತಗೊಳಕ್ ಇಲ್ಲಿ ಜಾಯ್ನ್ ಆಗಬೇಡಿ ಇಲ್ಲ. Ravindra sir,
Yes, madam.
voice is audible,
Yeah, the voice is audible.
clear, right?
Yeah, it is clear, madam. Yeah.
This is Sumuk.
Yeah, the Sumuk, ma'am.
Okay, fine, no problem.
Okay, ma'am. Thank you.
ಹೇಗೆ ಮಾಡಿದೆ ಸರ್?
Not okay with it.
Yeah.
ಅವ್ರು ಈ ಕಡೆ ನಾನು ಮೇಲ್ಗಡೆ
ವಿಜಿಲಿಂಗ್ ಕಳಿಸ್ಬೇಕಂತ.
ಮಾರ್ನಿಂಗ್ ಮಂಜನಾ.
ರವೀಂದ್ರ
ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಸರ್.
ರವೀಂದ್ರ ಸರ್ ರವೀಂದ್ರ ಸರ್ ಅವ್ರಿಗೆ ಬಿಜಿ ಸರ್ ಲಿಂಕ್ ಕಳಿಸ್. ಬಿಜಿ ಸರ್ಗೆ ಓಪನ್ ಆಗ್ತಾ ಇಲ್ಲ. ಅದು ಇಲ್ಲಿ ಓಪನ್ ಆಗಿರುತ್ತೆ, ಒಂದು ಓಪನ್ ಆಗಲ್ಲ.
ರಂಜಿತ್
ಪ್ರಿನ್ಸಿಪಲ್ ಬಂದು ರವೀಂದ್ರ ಸರ್
ಕನೆಕ್ಟ್ ಆಗಿಲ್ಲ ಅವರು.
ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಮಂಜುನಾಥ್ ಸರ್.
ಓ ಇಂಟರ್ವ್ಯೂ.
Not problem, later.
Just waiting for BG sir to log in, sir. He was having problem. BG sir is logging in. Sir.
Okay. think somebody should keep an eye on the Q&A. They are asking no audio. I have just typed them. The program has not yet started. So some questions may be coming up. Please, one of them be attending on to that Q&A and other.
Hello, sir.
Sure, sir. We'll keep a track on this. Thank you, sir.
Director has called for a meeting at 9:45.
You can announce that it will be starting in another 5 minutes or so, so that they will be. They think there is no audio. Program is going on.
We'll just start in 5 minutes.
We'll be starting in another 5 minutes.
ರವೀಂದ್ರ ಸರ್ಗೆ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತಾ ಇದೆ ಅವ್ರಿಗೆ ವೈಟ್ ಅಂತ ಮಾಡ್ತೀನಿ.
We are listening.
There are 153 participants already.
Audio ಇದೆ, audio ಕೇಳ್ತಾ ಇದೆ.
Start within 5 minutes.
Esteemed guests, dear participants, will be starting the inaugural function within 5 minutes. Sorry for the delay.
Am I audible, Dr. Manjunath?
Yes, sir. It is audible.
Actually, ಈಗ ಸರ್ 9:45 ಡೈರೆಕ್ಟರ್ ಮೀಟಿಂಗ್ ಕರೆದಿದ್ದಾರೆ. Is busy sir is also there. Just I received a phone call.
Okay. Because
ಈಗ 9:45 ಡೈರೆಕ್ಟರ್ ಕರೆದಿದ್ದಾರೆ ಬೋರ್ಡ್ ಇದಕ್ಕೆ ಬೋರ್ಡ್ ರೂಮ್ಗೆ ಅಂದ್ರು. ಪ್ರಿನ್ಸಿಪಲ್ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿ ಹೇಳಿ if is not this one you can continue, otherwise 142 people are there ಅಲ್ಲ on the line.
150 plus 155.
150 plus ಪ್ರಿನ್ಸಿಪಲ್ ಒಂದ್ಸರಿ ಕೇಳ್ಬಿಡಿ ಬಸವನಗೌಡ್ರನ್ನ ಅಲ್ವಾ, ಈಸ್ ಈ ಕಮಿಂಗ್ ಆರ್ ಕ್ಯಾನ್ ಸ್ಟಾರ್ಟ್ ಅಂತ.
You ask him to ask register and start it.
Sir, shall we start, sir?
You can start.
Okay, sir.
Pranams to lotus feet of His Holiness Jagadguru Dr. Shri Shivaratri Rajendra Mahaswamiji, seeking the blessings of Jagadguru Shri Shivaratri Deshikendra Mahaswamiji. A very good morning to one and all. Myself, Dr. Vinita SP, Assistant Professor, invite you all for the national webinar on challenges in the implementation of CBME curriculum in anatomy on behalf of Department of Anatomy, JSS Medical College, JSS Academy of Higher Education and Research. Now I request our beloved HOD, Dr. Pushpalata K, Department of Anatomy, JSS Medical College, who is the main driving force in conducting this webinar, to deliver the welcome speech. Over to you, madam.
Pranams to lotus feet of His Holiness Jagadguru Dr. Shri Shivaratri Rajendra Mahaswamiji, and seeking the blessings of Jagadguru Shri Shivaratri Deshikendra Mahaswamiji. Good morning to one and all. So the competency is defined as ability to do something successfully and efficiently, and CBME is an approach to ensure that the graduates develop the competencies required to fulfill the patient's needs in the society. So a significant attempt has been made in the CBME to provide the orientation and the skill necessary for lifelong care of the patient. So as a preclinical faculty, we have apprehension how to implement the CBME and especially like how to assess. So I think today's webinar will throw some light on this challenges, like how to implement the CBME. So for this webinar, I'm happy to welcome Dr. Manjunatha sir, Registrar, JSS Academy of Higher Education and Research. Welcome you, sir, for encouraging us for any of the activities from the department. Welcome you, sir. And I welcome Dr. P. Kushal sir, Director of Academies, JSS Academy of Higher Education and Research. Welcome you, sir.
Thank you.
And we welcome our beloved principal for encouraging and in all the
Thank
programs. Dr. S. Basangadappa sir. Welcome you, sir.
Thank you.
We welcome our Vice Principal, Dr. Suma MN and Dr. Manjunath sir, for encouraging us in all the programs. Welcome you, ma'am, and welcome you, sir.
Thank you.
I welcome our administrative officer, Mr. Satish Chandra sir, and welcome our speakers, that stalwarts in the medical education, Dr. Meenakshi, Dr. Nachiket sir and Dr. Deepti ma'am. Welcome you all for this webinar. And welcome my senior teacher and guide, Dr. N.M. Shamsundar sir, and all the faculty of anatomy for this program and for working as in a team. Welcome you one and all. Thank you.
Thank you, Dr. Pushpalata ma'am, for the warm welcome. Now I request our dynamic registrar, Dr. B. Manjunatha, Registrar, JSS Academy of Higher Education and Research, to deliver the inaugural address. Over to you, sir.
Thank you, madam. Seeking the blessings of His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji, it is my proud privilege to inaugurate this webinar. The Department of Anatomy has been in the forefront in many ways, whether it is right from the beginning. Because you see the very good mix of senior and young people there, starting from Dr. Shamsundar to the junior most faculty. The department has been very innovative in many ways. You can see, I just wanted to add a word or two about our university rankings and achievements. You see, we are ranked 33rd in India in the National Institution Ranking Framework, which is a ranking framework which is conducted by Government of India. And one special feature is the Atal ranking of institutions of innovation achievements. All the top institutions are engineering-based institutions here. But here we made a place here, and again, anatomy is playing a key role here, I should say. They not only restrict themselves to teaching, they are lending their hand in the medical education unit, in the genetics lab in the hospital, and they are teaching many more courses there. So this challenges, this webinar, challenges in implementation of CBME curriculum in anatomy is the need of the hour. So this, I think this webinar will open up more vistas and beyond the MCI or the new NMC guidelines which has been given for implementation of this CBME. I think this webinar will go one step beyond that, and because we have got all the stalwarts here, Dr. Meenakshi Swami, Dr. Deepti Shastri, Dr. Nachiket Shankar here. So I think this will be very useful, and the participants, I request all the participants to make use of this and interact with the speakers and clear their notes and give more ideas also. So we are welcome for anything. And I request, because this is a webinar, we are not able to see you in person. I think I request you all, when the situation is conducive, to visit our place, come to Mysore, visit the department and the college, hospital, and you will be seeing for yourself what work is going on here. I once again thank the entire department for organizing this event in a very systematic manner, and all the best. Thank you.
Thank you very much, sir, for the inaugural address. Now I request Dr. P.A. Kushalappa, Director Academics, JSS Academy of Higher Education and Research. Sir is always enthusiastic and always provides his support in conducting this webinar. Over to you, sir.
Thank you. Thank you, one and all. Seeking the blessings of His Holiness Swamiji, I first of all acknowledge and thank the organizers for giving me this honor. And I'm glad to be a part of the discussions that will change the way medical education is going to be taught. The Department of Anatomy has always led from the front, and with 2 FAMA fellows and all the faculty registered for PhD, one of them has already got her PhD. I think the Department of Anatomy is really glowing in this academy. And I congratulate Dr. Pushpalata and her team for organizing this very important national webinar. Challenges in implementation of CBME curriculum in anatomy. Although what is going to be discussed here will help in the implementation of this the competency-based medical education for the whole MBBS program. I think everybody can take a leaf out of the discussions which are going to happen here. And integrated teaching is a new mantra in medical education. Well, the aim of medical education is to train graduates in taking care of the health needs of the society. And medical education in its present curriculum, even we have been through this. It's subject oriented and the evaluations are summative. There is a little opportunity for feedback and analysis. We have all gone through the rigors of studying for the MBBS degree, where once we have finished the first year and the first MBBS, learned anatomy, and then we promptly forgot it during pathology and forensic medicine, only to be reminded of its importance when surgery and orthopedic classes were taken. Similarly, physiology was a closed chapter till we learned that its importance is so much needed to understand medicine. And the importance of biochemistry, we realized when we sat for the competitive exams like ESEF-MG and the other competitive exams. So here we are going to have a discussion on a totally different way how the medical education is going to be taught in the future. Great teachers we always had, but we as students did not realize the importance of connecting the various subjects and its importance in understanding a disease. Teaching, learning, and assessment focused more on knowledge than on attitude and skills, which are equally important as also soft skills, which are related to communication, doctor-patient relationship, and ethics. You can see many of the problems of today's patients attacking the doctors is also because we do not have maybe we have the competency, but we do not have the wherewithal how to communicate to the patient what is wrong and to the attendants what is wrong. And maybe this is one of the reasons where patients do not understand why a patient has died from a disease. So this is all going to be in the curriculum right from the MBBS stage. This is where the competency-based medical education has focused on tackling such issues. It ensures that a graduate develops competencies required to fulfill the patient's needs, replacing time-based training to train graduates in accountability, flexibility, and learner-centeredness. Competency is developed and continue to develop till the desired level is achieved. It's a continuous process and training continues to this end. Assessments also will not be just a matter of one bad day in the office where we have faced the tension of the viva and the theory where just one bad day in the office would determine whether we passed or failed. This is not the case now. The assessments will be more frequent and formative in nature. In addition, the feedback is inbuilt in the process of training. Not just the graduate, the teacher is also focused on this goal. Assessment is also more objective in nature and independent of other students' performances. It focuses on real life medical practice. Many a time we have seen many of the gold medalists not exactly taking very much interest in practice. And I'd like to add and end this short address by saying that today's national webinar on the topic will throw more light on the issues of implementation of the competency-based medical education curriculum. And this was introduced from the previous academic year by the Medical Council of India. The anatomy department has taken the lead in conducting this webinar. And I am very happy to have luminaries like Dr. Meenakshi, Dr. Deepthi, and Dr. Nachiket Shankar also will be joining us. And I again congratulate Dr. Pushpalata and her team for this wonderful organizing, and also the Dean of the Faculty of Medicine, Dr. BG sir. And I wish the webinar all success. Thank you very much.
Thank you very much for the presidential address, sir. Now I request Dr. H. Basavanagoudappa, Principal, JSS Medical College, to speak a few words. Over to you, sir.
Good morning to everybody. I take this opportunity to wish this webinar a grand success. I'm sure the Department of Anatomy has made all the efforts in trying to understand, trying to see the challenges involved in the implementation of the CBME in anatomy. I think the medical education unit has to influence other departments like physiology and biochemistry also to come forward and ask them to conduct such kind of webinar to implement the CBME in their respective subjects. As mentioned by Registrar as well as Kushalappa, it is very, very important to move ahead to understand the nitty-gritties involved in the implementation of the CBME, the learning and the evaluation. The teaching and learning and evaluation is very, very different in CBME pattern when compared to what we all learned. As mentioned by Kushalappa, one bad day would decide your fate. But here, the continuous teaching and continuous evaluation will go a long way in trying to nurture the students in a different way, and they will learn more applied aspects. They will be taught to apply that respective subjects in other components. I wish this program a grand success, and may make this infectious to other departments to conduct such webinars to make their subject to be implemented, implementation of CBME in their respective subjects. Thank you all. Wish you all the best for this program.
Thank you very much for your encouraging words, sir. Now I request Dr. Vidya CS, Professor of Anatomy, JSS Medical College, to deliver the vote of thanks.
Thank you. Good morning, one and all. With divine blessings of His Holiness, Jagadguru Sri Shivaratri Deshikendra Mahaswamiji, I feel honored and privileged to propose a vote of thanks on this occasion. First and foremost, I thank Dr. B. Manjunatha, Registrar, JSS Academy, for words of wisdom that radiated a source of energy within us. Thank you, sir. I also extend my thanks to Dr. P.A. Kushalappa, Director Academics, for his enormous support and gentle words of appreciation for the success of this webinar. Thank you, sir. I thank Dr. H. Baswangaudappa, Dean, Faculty of Medicine, JSSR, and Principal of JSS Medical College, who has been the driving force behind the whole process. My deep regards and thanks to Dr. Manjunath GV, Vice Principal Clinical, and Dr. Suma MN, Vice Principal Pre and Paraclinical, for the logistic support to organize this webinar. I must mention our deep sense of appreciation for our speakers today, Dr. Meenakshi Swami, Dr. Deepti Shastri, and Dr. Nachiket Shankar for the kindness to accept as guest speakers for today's webinar. I thank Mr. Satish Chandra, Administrative Officer, and his team for conducting this webinar. Finally, I will thank all the participants who have registered for this webinar from various parts of the country. We are fortunate enough to be backed by IT department, Dr. Ravindra and his team for their involvement in organizing this webinar. My sincere thanks to Dr. Pushpalata K, HOD, Dr. Shamsundar NM, Senior Professor, Mr. Manjunath HN, Coordinator, and all my fellow colleagues of Department of Anatomy for extending their warm support. Thank you, one and all.
Thank you, Dr. Vidya, ma'am. Now I request, now the scientific sessions will start. Now I request Dr. Najma Mabin, Associate Professor, Department of Anatomy, JSS Medical College, to introduce the speaker, Dr. Deepti Shastri. Over to you, madam.
Good morning, everyone. It gives me immense pleasure to introduce Dr. Deepti Shastri, Professor and Head in the Department of Anatomy at Vinayaka Missions, Kerupananda Warrior Medical College, Salem, Tamil Nadu. She has a teaching experience of more than 22 years and has held several academic positions. To mention a few, she was the resource faculty CBME Anatomy since August 2020. She is the member of Board of Studies in Kerala University of Health Sciences since May 2020. She is the Deputy Dean of VMKV Medical College, Salem since November 2019. She is the President, Association of Anatomists, Tamil Nadu since 2019. She is the member of Curriculum Committee, Institutional Ethical Committee, and Academic Coordinator of VMKV Medical College. She has been a resource person, organizer, and moderator for various faculty development programs and webinars related to the curriculum implementation. She has published several articles in national and international journals. She has been conferred with the Best Scientific Concept Paper Poster Award by Father Muller Medical College, Mangalore, and Dr. M.M. Cooper Memorial Award for Teachers by the Association of Anatomists. She has been awarded with innumerable certifications related to medical education and curriculum implementation support programs. With this brief introduction, I humbly request Dr. Deepti Shastri to help us to enrich our knowledge about early clinical exposure. Madam, please proceed.
Over to you, ma'am. Deepti, ma'am, you can share the screen.
Next, Deepti ma'am. Number ಇಲ್ಲ ವಿದ್ಯಾಗೆ
Deepti madam. Deepti madam.
ಲಾಗಿನ್ ಆಗಿಲ್ಲ ಅನ್ಸುತ್ತೆ. ಲಾಗಿನ್ ಇಲ್ಲ.
ನಮ್ದು ಸ್ಟಾಪ್ ಶೇರ್ ಕೊಡ್ಬೇಕು ಅವ್ರಿಗೇನೋ ಪ್ರಾಬ್ಲಮ್ ಸ್ಟಾಪ್ ಶೇರ್ ಕೊಡ್ಬೇಕು ಸ್ಟಾಪ್ ಶೇರ್
Suma, what is happening?
Madam, ಇದು ಏನ್ issue madam?
Is there any technical problem or what?
Yes, sir, the link also is not able to join, sir.
Fill up the gap with something going on till
Yes, sir,
login. You can keep talking about the highlighting points in anatomy, the CBME aspect. Author denaru points idre aagta iri till he logs in. Let the audience not feel blank.
Is it Deepthi D anta?
Deepthi Shastri, sir.
ಅಲ್ಲ ದೀಪ್ತಿ ಡಿ ಅಂತನಾ ಡಾಕ್ಟರ್ ದೀಪ್ತಿ ಡಿ
Deepthi Shastri. Dr. Deepthi
Pushpa,
Shastri.
till
Yes,
she
sir.
logs in, somebody keep in touch with her and till she logs in.
Yes, sir.
Please start talking about the highlighting points of CBME and anatomy
Yes, sir.
so that the audience who have logged in 200 plus should not feel blank.
Yes, sir.
Okay. Oh, the speaker.
So good morning, all the participants. So there is some technical issues. It's getting connected with the speakers. So as all of us know, as an anatomist, how, because already we have implemented it in the first year, it's in the process of getting going for the assessment methods. So we thought we'll have this webinar where we're concentrating more on the assessment methods from the global perspective as well as from the Indian scenario. So that's why we have Dr. Nachiket Shankar sir, Dr. Deepthi and Dr. Meenakshi. So as we know, the challenges, what we have, one thing is how the early clinical exposure. So though there is a lot of theoretical knowledge on how to go about the early clinical exposure, but exactly how to conduct, how to expose the first years, the preclinical phase itself, how to expose them for the clinical knowledge is a challenging one. Though MC has given some criteria, so and each institution have their own do's and don'ts and they're following it. So where the early clinical exposure, there's a different methods we are going to follow. So on that, which one to adopt? And those are the things we are going to discuss. So now we have, there are some technical issues with the first speaker. So we'll go with Dr. Nachiket Shankar sir. So he'll be presenting the how to make the case scenarios for the assessment, especially for the theoretical knowledge, the assessment methods. So we'll just start with the another speaker, Dr. Nachiket Shankar sir.
Now I request Dr. Deepa Bhatt, Associate Professor, Department of Anatomy, to introduce the speaker, Dr. Nachiket Shankar.
Good morning, everybody. It is indeed my pleasure to introduce Dr. Nachiket Shankar, the man known for his simplicity. He is a professor from the Department of Anatomy, St. John's Medical College, Bangalore. He is passionate about working towards medical education, and he's also into sports. And he is a man who has played a pivot role in designing the competencies for our new CBME curriculum. So now he will be addressing to us on preparation of case scenarios in teaching and assessment. Welcome you, sir, and over to you.
So thank you so much. Good morning to all the participants and all the dignitaries. And it is indeed a pleasure and privilege for me to be part of this program. And like was already mentioned in the inauguration, this is a great platform for all anatomists across India to share the knowledge that they have, so that translates to our students becoming more competent doctors. So I'm going to start sharing my screen now, and we will begin the presentation shortly. So I just want to confirm that my screen is visible.
Yes, sir.
It's visible, yeah. So the other thing is that I would like this presentation to be as interactive as possible. So if any participant has any question or point to make, they are free to unmute themselves and interrupt me as I present. So any participant or panelist has a point to make, you can please interrupt me as I'm making the presentation so that this is as interactive as possible. At the end of the session, if we do have some time, we can get experiences from other anatomists as well. I'm sure there are many more experienced anatomists here than me, and we can learn from each other. So without further delay, I will start the presentation. So this presentation is titled Case Scenarios in Anatomy for Teaching and Assessment. And as we all know, knowledge is like paint. It is no good until it is applied. And I thought that this was apt for this presentation because very often anatomy is considered a very factual subject and which is soon forgotten after the first year. But that should not be the case because it forms the foundation for medical practice. So what we're going to explore is this presentation is going to be in 3 parts. In the first part, I'm going to make a case for case scenarios and why case scenarios are required in the current scenario. Okay, so the need for case scenarios. The next part of this presentation is going to actually deal with the use of case scenarios for teaching and assessment. And for this part of the presentation, I'm going to use the experiences that we have at St. John's in creating case scenarios to give you some examples. And we can also take examples from all the esteemed participants and panelists who are present here. And finally, I'm going to end the presentation by sharing a few guidelines for the creation of case scenarios so that they are able to achieve what they're supposed to achieve. That is the ability to apply anatomical knowledge. So this is going to be the structure of my presentation or the anatomy of my presentation. So we're going to look at the need for case scenarios and the use of case scenarios for teaching and assessments with examples and ending with guidelines for creating case scenarios. So let's start off with the first question. Do we need case scenarios at all, right? So let's have a 2 or 3 minute discussion about this. And I encourage all the other panelists and the participants to participate actively in this discussion, right? So since we will use the unmute option. So is there a need for using case scenarios in anatomy for first MBBS students? And this question is not as stupid as it sounds, because there are some people who believe that we should first look at normal and only then proceed to look at abnormal, right? And case scenarios all deal generally with abnormal. So your thoughts on this, please. Yeah, so I'm seeing some responses in the chat. They say it is absolutely needed. There is a need for case scenarios, definitely needed. Need of the day, yes. Could you please, should be very basic at the start. Okay, that's a great point. We should, the case scenarios should be appropriate for the learning needs of the students. Yes, definitely it's useful for understanding the normal. It is, context should be understood, great, to kindle interest. Okay, is there any counter view here? Is there anyone of you who feels that maybe case scenarios introduced in the first year is too early? I'm saying this because when I was a medical student, we used to have this applied anatomy section, and I did anatomy in 1994 and 95. At that time, there was very little use of case scenarios. Though, of course, we had applied anatomy, there was very little use of case scenarios. Okay, so some people feel it's too early. They should know what they are teaching in the chapter. Yes. First normal and then introduction of the case. Yes. So I'm happy to see that there's a lot of active participation amongst the faculty. So please think about this question as we proceed. So I'm going to proceed with the topic. And this part is going to look at the need for case scenarios. Okay, so before we go on to case scenarios per se, let's look at the role of basic sciences. What is the role of the basic sciences? And by basic sciences, I mean anatomy, physiology, biochemistry, path, micro, pharmac, all the basic sciences. And this is a paper that was published in Medical Teacher. And the author makes a case for basic sciences in 3 areas. One is to support clinical reasoning skills, right? To help clinicians and students to come to a diagnosis, right? That is clinical reasoning skills. The second role is to support the practice of evidence-based medicine, right? So basic sciences are important in the practice of evidence-based medicine. And finally, basic sciences are also useful for the system as a whole to understand the science of healthcare delivery. But for now, for our undergraduates, perhaps the second and third ones are a little more advanced for our undergraduates. The role of the basic sciences is perhaps most important for developing or honing clinical reasoning skills, right? That is, they have to use the basic sciences in a clinical context in order to make an accurate diagnosis, right? So that is the main role for the medical students of basic sciences. And by basic sciences in this context, I'm saying anatomy. Right? And there is evidence from literature. So please don't get scared by all these numbers. So what this means is that students who have good basic science achievement, that is, who have scored well in exams related to the basic sciences, their clinical reasoning skills are also better, right? So there seems to be a significant association between basic science achievement and clinical reasoning skills. So there is evidence from literature to show that the basic sciences are useful for making a diagnosis. And this is quantitative evidence, though from abroad. This is another paper that was published in 2016, where the students were physiotherapy students. And what this graph shows is that the bar in blue shows the ability to make an accurate diagnosis when basic sciences, especially anatomy, was incorporated into the teaching. Right? So they had clinical cases and the basic science correlates were incorporated into the teaching. Whereas the red bars were where only the clinical aspects were dealt with and basic science was not given much importance when the case was discussed. And we can see that in the future, we can see that the diagnostic accuracy was significantly better in those students in whom the basic science concepts had been incorporated into the clinical case. And this difference persisted even after 1 week. Okay. So in this example, this was an example of Dupuytren's contracture. And when the basic science aspect, that is the palmar aponeurosis and its thickening and what role it has in deformity, the diagnostic accuracy of the students improved. So there seems to be strong evidence to show that basic sciences, that's including anatomy, are very important for making an accurate diagnosis. So that being the case, what is the problem? So currently, and there is a change now with CBME, it is a very fact-filled anatomy curriculum, right? You would agree with me that there are a lot of facts to be memorized. And many or most of those facts have little clinical relevance, right? So that is a problem. The second problem is knowledge decay with time. I think right from time immemorial, we as medical students, when we go to the second year, we are asked some questions by the surgeons and we are completely blank. And they say, come on, man, you have just finished your anatomy and you don't remember this, So most of us don't remember it. And this probably, by the time we reach final year, we remember very little of our basic science. So it is a practical problem. There is a knowledge decay with time, right? And like one of the, in the introduction, one of the dignitaries rightly mentioned, integration is the need of the hour. And without integration, there's going to be a significant knowledge decay and students are not going to be able to apply anatomy in the clinical context. So the third one I come to that is the inability to apply information. Just because they know the facts doesn't necessarily mean that they'll be able to apply those facts. Okay? So that implies that we need to ensure that the students are able to apply what they learn. So these are the three major problems with the anatomy curriculum, right? Full of facts, there is a decay of knowledge with time, and there's an inability to apply those facts in a clinical setting. And therefore, because of these problems, students are not able to, that basic science or anatomy is not able to effectively contribute to the clinical reasoning skills of medical students. So this is evidence from literature. This was a paper published in one of the medical education journals, which shows the amount of decay of basic sciences as the years progress. That is, if basic science is not revisited, this is the decay. So 33% is lost at the end of 1 year, 50% at 2 years, and greater than 2 years, there is a more than 50% decay of knowledge. And this is another very nice paper in Medical Teacher by a famous medical education person, Dr. Norman. And he says that students who have learned a concept in one problem context will have only a 10 to 30% success rate in applying the concept to solve a new problem, right? I think we have all faced this with maths with our children. When just because they're able to solve one problem in one context doesn't mean that they'll be able to solve another problem in another context. So I'm going to give you an example to explain this. This is Newton's laws of motion, right? This is physics. And let us say that a student is able to solve a problem related to a ball that rolls down a slope, right? That same student may not be able to solve this problem here, in which there is a trapeze artist and the forces on the rope. And they may not be able to solve this problem, which is related to pulleys. Though the underlying principle underlying all these problems are the Newton's laws of motion. I hope I have made myself clear. So these are problems which utilize the same basic principle, but just because a student is able to solve this problem of a ball rolling down a slope doesn't necessarily mean that the student will be able to solve the other two problems. And the same thing applies to anatomy and medicine as well. Just to give you an example, let us say that this is a patient with referred pain in the, let's say, of the abdominal wall for an abdominal condition. Just because the student is able to solve this problem doesn't necessarily mean that the student will be able to say solve another problem of referred pain in relation to renal colic, which, and another problem, let's say the pain of a myocardial infarction, right? So unless we expose the students to multiple examples multiple times, they may not be able to use the concept in different situations. So what are the possible solutions to this problem, right? So this is again evidence from literature. If only a principle is taught, let us say that I'm going to take the previous example of referred pain. Let us say I just mentioned to the students that referred pain is the pain felt on the outside, on the skin of a structure that is present within the body, a viscous, and I don't give any examples. The student may not be able to solve a problem related to the concept of radiation or the pain referral. There's only a 5% chance. However, when teaching referred pain, let us say I give the example of myocardial infarction, right? Saying that the nerves that supply the heart also supply the chest wall and the left upper limb on the inside aspect. So that's why pain is referred to the inner aspect of the left upper limb and the chest wall, right? The transfer or the ability to solve problems that's transfer goes up to 25%. And if you give multiple examples, the transfer can be as high as 50%. So this is just to drive home the point that the more examples we give for a particular concept, the greater likelihood that the student will be able to then use it in a clinical context. And the two basic solutions are embedding principles on problems. That is, you combine both, right? So this is counter to the argument that we need to first do normal and then abnormal. So it's nice to do normal and abnormal together, right? So the principle is related to the normal and you put a problem in there so that they can use that principle to solve the problem. And the second is using multiple examples, like I've already mentioned, with active student participation. And the use of case scenarios is in line with these solutions. You embed the problem on a principle and you use multiple scenarios in multiple contexts. Then the students will be able to utilize those case scenarios for their learning very effectively. So I hope I've made a strong case for the use of case scenarios in anatomy. Now I'll come to the main topic on how to use case scenarios for teaching and assessment. So before we start, I'd like the participants and maybe some of the panelists, if they so wish, to share your experiences with using case scenarios for both teaching and assessing anatomy. So I'm going to pause for some time and we can take some input from the participants and the faculty. Okay, so there's a question by Dr. Deepa Bhatt. Even when this pattern of teaching did not exist, we have produced best doctors. How is it going to make a difference now? So I would say that, yes, we have perhaps been doing a reasonable job even in the past, but I think there is evidence from literature to show that perhaps we can produce even better doctors now by using evidence from literature and using case scenarios. So I'm not saying that what was done in the past was wrong or bad, but there's certainly a scope for improvement. And I think that quest for improvement should never stop. And this is one step in that quest for improvement. And of course, how is it going to make a difference? We will not know immediately because evaluation of a program takes a long time. So it will take perhaps 5 or 6 years till we evaluate what the impact of CBME has had on the medicine landscape before we can actually draw a conclusion as to whether it's better than before. Second question by Dr. Shirish is, do we have a robust assessment system which can be used to correlate the performance of a student in basic science with good clinical skills? Yes, sir, there are a number of tools that can be used which can do this. And there are some tools like what is called a script concordance test, in which the judgment of experts is compared to the judgment of medical students. And we can certainly incorporate some basic science aspects into those types of examinations. So I think there's an important point there. We do need to incorporate the basic science with the clinical skills, especially in the assessment. And perhaps we can start doing studies in which we try and look at the correlation or the association between basic science performance and clinical skill performance. There is already evidence, but maybe we can do that in India. Thank you, sir, for bringing up that point. Any other? So you can.
So in the chat box, there is a few of the comments are there, sir.
Okay, madam. I'll take a look at that. Okay, so Deepthi ma'am has said we have been using case scenarios even before introduction of CBME. Okay, so that's, I think, a great sharing. Case scenario should have diagnosis within the case scenario or framework or not, from Dr. Ajay Kumar. We will come to that maybe a little later, sir. So maybe our emphasis should not be so much on diagnosis, but on how the structural aspects help to explain the clinical findings rather than the diagnosis. Maybe diagnosis per se may not be that important for the first year. case scenarios. So conventional anatomy has been using case scenarios in the form of OSPE. Yes, we shall come to that. So especially certain things like surface marking are amenable to OSPE and muscle actions. Yeah, so I think you have used, I think all the points that I'm going to talk about have come in there. Case scenarios are ideal to be used in a lecture for set induction. I think that's a nice point there. Yes, use the lecture more, it makes the lecture more interesting. Even in these days, neat questions are in the form of cases. Yes, so that's an additional incentive for the student to pay more attention to case scenarios. So great points there. So we will be looking at using role plays for case scenarios. Yes, madam, we can use role plays as well for case scenarios, and maybe the affective aspects can be brought out well using role plays. So pictorial presentation, ECG, we can use case scenario. Yes, thank you for that sharing. So most of the points have been brought out. So I will proceed with the presentation. So this is called Bloom's taxonomy, and those who have attended medical education workshops will be very familiar with this. So there's a various level in the cognitive domain. There are three domains, basically the domain of thinking, that's cognitive domain, the domain of doing, that's the hands, that's a psychomotor domain like suturing, and let's say doing hand skills like performing catheterization. And the third domain is the affective domain, right? Which also includes communication, empathy, right? How we deal with other human beings. All three are very important. But in the cognitive domain, we have various levels. And the first level is just remembering or memorization. Right? And we use verbs like list, find, name, define, etc. And in the past, anatomy used to be mainly at this level, right? We used to focus mainly on the facts, and we didn't care too much about the understanding. So understanding is one level higher, in which they are able to comprehend the facts and understand a little deeper about why those facts are important, right? So we use terms like interpret, summarize, explain, discuss, etc. Right? So this is understanding or comprehension. The third level is application, where they utilize those facts and that understanding and apply it in a particular context. For example, in a clinical case, right? So that is the application. And at the higher levels, we won't go into all the terminology because sometimes it's confusing. We go beyond application, where they actually create, for example, creating a treatment plan for a particular patient is quite difficult, right? It goes beyond application. So they have to create, evaluate, and analyze. So all these are the higher levels in the Bloom's taxonomy. And by using case scenarios, we are moving beyond remembering to understanding and application. Okay, so that's the role of case scenarios in teaching. And with the new CBME, many of our learning objectives will be higher, of the higher order, right? Not just list, name, etc. Sorry, sir, some questions? Okay, so I'll move on. So where do we use case scenarios for teaching? We of course use it for lectures, like someone said, for set induction, for creating interest amongst the students. We can use it very well in dissections. As we are doing dissections, we can have case scenarios related to the dissection. And now there's a specific subsection. Dr. Deepthi was going to speak about this in more detail during her session, called early clinical exposure. And one component is called the basic science correlation, where they suggest that case scenarios be used to discuss anatomy in a context, in a clinical context. We can use it very effectively for integration as a linker session. And so these are some of the areas where we can use case scenarios for teaching. And when I say lectures, I mean all types of lectures. I'm including osteology, I'm including histology, gross anatomy, embryology. You name the lecture, we can use a case scenario in that particular context. So let's look at some of these examples. These are all examples from St. John's that we have used. So this was a lecture on the development of the GIT, and this is how the class was started. A 32-year-old male patient was admitted with a history of recurrent episodes of postprandial vomiting for the past 8 months. So with this, there seems to be a hint that there may be some sort of intestinal obstruction because the food that goes in is not able to pass distally. It comes out in the form of vomitus. The upper GI endoscopy revealed a small benign ulcer at the pyloric area. So that shows maybe there was pooling of acid because it could not move down, and that irritated the gastric lining, producing a benign ulcer. So all evidence of some sort of obstruction that is somewhat proximal, right? A proximal obstruction of the alimentary canal. The barium meal is shown over here, right? And you can see that there's a filling defect in the center here in the in the barium meal. There's a filling defect, and after that, an abdominal CT revealed a ring of pancreatic tissue encircling the second part of the duodenum. Okay, so this was how the lecture was started, and we revisited this case as we progressed through the lecture, and we did development of the pancreas, and we came to the topic of annular pancreas and why it occurs. And at the end of this class, we then use this case scenario to recap the development of the pancreas. So during the lecture, a case scenario can be used very effectively, not only for set induction, but also for understanding the contents of the lecture and also during summarization. So it's very useful to use a case scenario during a lecture. And it could be, for example, this was a lecture on the shoulder joint, and here's a patient with dislocation of the right shoulder joint. So it doesn't always have to be a text, it could be a picture as well. And I can, or the teacher can give a story about what happened to this patient, and the students can be asked to compare the right and the left, right? And then as the class progresses, they should be able to explain why it looks like this and why it looks like this. So it's a very useful way of engaging the students during the lecture, the case scenario. It could be in the form of a video. For example, this was a class on the midbrain, and this was a video that was played for the students.
Parkinsonism.
Yes.
Yes.
So these are various ways in which case scenarios can be used during lecture. So this was someone mentioned Parkinson's gait, Parkinson's disease. So during a lecture of the midbrain, this is a very nice case scenario to look at through the lecture. Okay, so I'm going to move on. Where else can we use clinical case scenarios? Almost anywhere else. So I'm going to give an example of the use of case scenarios during dissection. Early clinical exposure, basic science correlation, or it could be even a linker session. Okay, so this was a dissection of the pectoral region and breast, and this was the case. I've split it up into 2 or 3 slides so that it's easier to read. So a 55-year-old nulliparous female complained to her family physician of a hard, painless lump in the right breast, which is shown in the picture. Right? So you can see here there is visible swelling. There seems to be an abnormality of the skin over here, like a peau d'orange appearance. There seems to be some retraction of the nipple as well. So using this and continuing the case scenario, there were also 2 swellings in the right axilla, and on examination there was an abnormal appearance of skin over the swelling, loss of mobility of the breast, alterations in the position of the nipple, and enlarged lymph nodes. As someone very rightly pointed out, it should be appropriate to the learning level of the student. You can see here, each of these has an anatomical explanation. The abnormal appearance of the skin, peau d'orange, has an anatomical explanation. Loss of mobility has an anatomical explanation. Alterations in the position of the nipple has an anatomical explanation. Enlarged lymph nodes have an anatomical explanation. So, like someone mentioned, diagnosis per se may not be very important in the first year, but they need to explain the clinical features. That's what is important. Use anatomy to explain clinical features. A radiograph of the vertebral column revealed shadows in the vertebral bodies of T6 and T7. And fine needle aspiration cytology was done and a diagnosis of carcinoma of the breast was made. Right? So we are giving them the diagnosis. And we are also introducing them to new terms. That's also very important for anatomy. Nulliparous. Right? We are introducing them to fine needle aspiration cytology. Right? So it's also important to introduce students to clinical terms that will be used later. Okay, so these are some of the questions that were asked in relation to that case scenario. What is the name given to the abnormal appearance of skin over the swelling? Explain its anatomical basis. Slightly higher level, they have to explain why it is there. What is the terminology that is used to describe the alteration in the position of the nipple? What could be the reasons for the loss of mobility of the breast and alterations in the position of the nipple? So here they would be expected to talk about the connective tissue framework of the nipple and the lactiferous ducts. What would happen if carcinoma infiltrates those two structures? How it causes an alteration in the appearance of the breast. Then we come to the lymphatic drainage of which lymph nodes are likely to be involved. They have to link the swelling in the axilla to enlarged lymph nodes. And they have to explain why those lymph nodes are more likely to be involved. And then they have to look at the metastasis to the vertebral bodies and explain how the venous drainage of the breast is related to the metastasis in the vertebral bodies. So this is pretty complex, but very strong anatomical basis for explanation. Okay, so those are some examples for use of case scenarios for teaching. Would anyone like to add anything here? You can please unmute yourselves and add something if you would wish to. I'm just going to move to the chat. Okay, so that's a very good question. Is it possible for first year student to be familiar and remember so many new terms in the first year? Already we are bombarding them with so many new terms in basic subjects. That's an excellent point, madam. Excellent point. What we can do is it has to be slow and it has to be appropriate for their learning. So like you have mentioned there, we maybe have to introduce one or two terms at a time rather than introducing multiple terms at one go. So I think it should be done in a very slow and systematic manner. Otherwise, we're just going to confuse them. So if it's slow and systematic, perhaps it's going to improve their learning. And someone has said visuals always provide a better memory. Yes. And very good ideas. Fresh dead bodies post-mortem can be shown to first year MBBS students. That's a great idea, sir. Yes. All case scenarios will have new terms. Yes. So that's another both problem and an advantage. So they learn those new terms. On the other hand, if we bombard them with too many new terms with case scenarios, it's going to confuse them. I think that's important to keep in mind. Let's not introduce too many new terms in the case scenario. Restrict it to 2 or 3 new terms. Time constraint, yes. But now I think with the MCI thing, there's specific time allotted. So we have a good 18 hours for basic science correlation. So that can be dedicated entirely for this process. Okay, so we're going to move on now to the use of case scenarios for assessment. And I think all of you will be familiar with this framework for assessment. It's called Miller's Pyramid and it has 4 levels, right? This is mainly meant for assessment of competencies. So the first level is nose. We are assessing nose, right? It's all factual information. It can be assessed in many ways. It can be paper-based testing. It could be MCQs. It could be short answers, long answers, etc. Any method, many methods are used to assess facts. That is nose. But we know that this is not enough. We need to push the students a little higher. And this is knows how. That is, knows how to apply those facts in a clinical context, or is able to understand those facts, the why questions and the how questions. That is knows how. And this, of course, is at a later stage. It may not relate directly to anatomy, though, for example, for surface marking, maybe this relates to that, shows how. This is basically the skills based, right? For example, the student does a catheterization in the skills lab and it's assessed there. Or the student does suturing on a model in the simulation center. That is shows how. And the does level is basically this assessment is probably only when the student is an intern. This is in the workplace. So when the intern is in the workplace, is that intern able to perform do what he is supposed to do, he or she is supposed to do effectively. And there are various tools that are available that are clubbed together as workplace based assessments. But for this session, we're going to restrict to knows how, that is knowledge based assessments, which are case based, right, which test a higher level in the of the student. So we're going to move on and look at how cases can be used for assessment. It can be used, of course, for long essays, short essays, short answers, MCQs, Viva and OSPI. It can be used in all these scenarios or all these situations. So I'm going to give examples for each of these. Okay, this is an example of a question that we gave our students for internal assessment, and I'm sure all of you are doing this. This is just to give you an example. A 50-year-old female came to the OPD with complaints of difficulty in breathing and pain on the right side of the chest, radiating to the anterior abdominal wall. On auscultation, there were reduced breath sounds over the right lower aspect of the right lung fields, and chest radiographs revealed that this patient had a right-sided pleural effusion. Here again, we are not so much interested in the diagnosis, but the student should be able to explain, give an anatomical explanation for many of these findings. For example, the pain of radiating pain, why it goes to the anterior abdominal wall, why were there reduced breath sounds, right? So they can give an explanation. So basically what we are targeting is their understanding of the pleura and the chest wall. So that's what we are targeting over here, their understanding of the anatomy of the pleura and chest wall. So not all questions are related to the case scenario per se. Okay, so we are sort of having questions that are related to this region, but not directly related to the case scenario. So for example, we start off with define a typical intercostal space, and then we move on to the pain felt by the patient and how it can be explained. All the ones that are related to the clinical aspects are highlighted in black, bold and italicized. Then what is pleural effusion, right? Okay, then we come to a little higher level. When performing a pleural tap, where in the intercostal space is the needle introduced? What is the anatomical basis of this location? So we want them to say that it's not in the upper part of the space because that's close to the costal groove, which may damage the structure. So we want them to answer that. And why is paracentesis usually performed where it is usually performed? Okay, so this is to prevent damage to the other structures that are present in that region. For example, it could be the spleen on the left side, right, which is located between the 9th and the 11th ribs. So all the ones in black are the places where the students have to apply the anatomical knowledge in a clinical context. So this is an example of a long essay, and this is the subdivision of the marks. Coming to the short essays, after a difficult delivery, a neonate was found to have an abnormality of the left upper limb. The left arm was held in an adducted position in contact with the thoracic wall. The left forearm was held in an extended and pronated position. This, of course, as we all know, is Erb's palsy. And in this case, since we emphasize so much, the student would be expected to know the name, right? And this is a core competency, I think, that is given. So there's no harm, I think, in certain places for the students to identify the condition itself. Second question is draw a neat label diagram to show the site of injury. So basically, we want them to draw the Erb's point and show those 6 nerves meeting at that point. And then here is the clinical application. Explain the anatomical basis of the deformity. So here we expect them to say that C5 and C6 are affected because it's the upper trunk, and those supply the deltoid and the biceps brachii. Because the deltoid is not able to act, the arm is adducted, and because the biceps is not able to act, the forearm is extended and pronated. So this is what we would expect from the student. And 1 + 1 + 3. And short answers. An example, a 70-year-old patient diagnosed with a myocardial infarction showed a significant block in the trunk of the left coronary artery when a coronary angiography was performed. Explain which areas of the heart are likely to be affected by the block. Pretty simple, but still they have to know that the distribution of the left coronary artery, and they have to know that those areas are likely to be affected by the block. So here again, it's not so much, this is more a context providing mechanism. We provide some context so that students are able to relate the blood supply of the heart to a myocardial infarction. And this is an example of an MCQ. I think in the interest of time, I will not read it out. This is related to malrotation of the small intestine. So basically, this would be linked to a class on development of the digestive system. And they would be able to sort of, this is for formative assessment, right? It's basically a midgut volvulus. That's because of the fact that the intestine is not fixed. There's some abnormality in the fixation of the intestine. And here we are giving them feedback, right? As to why, which answer is correct and why it is correct, and why the other three answers are likely to be incorrect. So MCQ is very, very powerful tool for formative assessment. So certainly we can incorporate case scenarios into multiple choice questions. So I finished two parts of the session. One is why we need case scenarios, and second is giving examples of case scenarios. And I just want Pushpa ma'am to please tell me how much more time I have, ma'am.
Sir, 15 more minutes, sir, with the discussion.
Okay, ma'am, I can comfortably finish in 15 minutes. Thank you so much, ma'am. Thank you so much. So we will have a little bit of sharing here. So we'll come to the question and answers. Let's see how to integrate the linker cases. Yes, sir. So I think I'll give you an example. In our department, what we did, I was one of the other faculty was involved. She used team-based learning for linker case. So what she did was she coordinated with medicine, biochemistry and physiology. All medicine, physiology, biochemistry and anatomy came together and developed a case of myocardial infarction, right? In which the physiology component was included, the biochemistry component was included, the anatomy component was included, and the clinician also was included so that the case was authentic. And what happens is that when clinicians come into the picture, authenticity increases because they know the most common presentations. However, sometimes they forget that the basic science correlates are important for us. So therefore, it's very nice for a team to come together and create a case. And integration will be better when the team creates the case rather than an individual creates the case. One attendee said, how much percentage of clinical knowledge do teachers have to remember over a period of time to efficiently teach clinical anatomy? They start forgetting because they lose touch with practice. Very true, sir. Very true. I think what we can do is we can use the competency framework to guide us through this. So we have that list of competencies and we have the list of applications as well in those competencies. So maybe we as anatomists can orient ourselves specifically to those areas initially and then later to other areas. So my answer to that would be that perhaps we can use the competency framework to guide us as to which areas that we as anatomists need to concentrate on. There is a need for teaching or review to non-medical teachers as they lack experience of patient care. Certainly, sir, but it can certainly be taught. So maybe there needs to be a little more emphasis now that CBME is coming in, especially for those from a non-medical background. I agree with you, sir. Maybe a little more emphasis on including them in the whole process is required now. Will it be possible to use case scenarios for all lecture classes? What I would say is it is not required to use case scenarios for all lecture classes, but I think it is certainly possible. It is certainly possible because I think in medicine, in anatomy, anything can be linked to a case scenario. But is it required? maybe not in all lectures. Teaching normal anatomy progressively weaning if we go into the depth of the case. Fully agree, sir. Fully agree. We don't need to go into the depth of the case. We need to constantly remember how anatomy is useful for us to explain the clinical features in the case. So that's the depth that is important. We don't need to go into the diagnosis, into the detailed investigations, all that, because I think from experience, students will tend to remember that rather than anatomy. Okay, let's go to the chat quickly and see some of the things there. Problem with coordination with other departments and carrying on to other departments. Yes, that's true, sir. But I think we need to take time, and many faculty from other departments have now been sensitized because of CBME and are more amenable for cooperating. TBL is very effective. Yes, sir. External examiners also are changing, sir. They will also have to change with CBME. External examiners will also have to change. We will all have to change, but the change process will be slow. Exactly. So, madam has said that we need students to know anatomical or embryological basis. Exactly, madam. That's what we are looking for. Okay, we will move on. This is the last part of the session. These are a few guidelines for creation of case scenarios. So we will come to your experiences maybe a little later. So I'm going to share our experiences at St. John's in creating case scenarios. And some of these tips I've taken are from a paper for problem-based learning, which is titled 12 Tips for Constructing Problem-Based Learning Cases. So I've just modified it a little for our purposes and cut it down to 8 tips. Tip number 1 is establish writing teams, right? So one person should not be given the task of writing a case, right? So within the department, you can have a few teams that sit down together and write a case. And it would be great if clinicians are involved, even at the end, after you write a case, if you can run it through a clinician, that would be great. So I think most important is to establish writing teams. It's very important to establish because the clinicians provide the authenticity and the basic science teachers will ensure that that case has relevance for the medical student at that particular level. So tip number 1 is please do not write cases alone. It should be in a team in the department, and it would be great if you could include clinicians. Every case should be linked to educational objectives. It should not be a case just for a case sake, right? Like someone said there, then the students will get so involved in other aspects that they will forget that this case should be linked to anatomy, right? For example, if you remember the case related to breast cancer, there were very specific objectives that were targeted. For example, the structure of the breast, the lactiferous ducts, the lymphatic drainage of the breast, the venous drainage of the breast. So all those were the educational objectives that were linked to that case. So it's very important to link the case to educational objectives. Tip 3 is to create an engaging case scenario, right? And what guidelines say is that it should not be more than 10 lines, ideally around 5 lines or so. That's the maximum, right? So it should be crisp yet engaging. So that takes time to create, and but it's time well spent, right? So create an engaging case scenario. Tip 4, as has already been mentioned, anatomy is a very visual subject. So as wherever possible, incorporate images into the case. So images are a very powerful tool of learning for students. So wherever possible, incorporate images into the case. Tip number 5, please think about authenticity. It should be related to real life. It should not be very hypothetical. It should be amenable to integration. So let it incorporate elements that make it amenable for integration. This is especially true for the case that is used for linker sessions. And it should have a logical flow to it. It should not just move from history to physical examination to investigations just randomly. Okay, so there should be a logical flow to the case. We've already discussed this. Adjust the cases to students' needs. I really like this, what was mentioned here. Great teachers engineer learning experiences that put students in the driver's seat and then get out of the way, right? So in order to put the student in the driver's seat, they need to be comfortable in the car, and that car should not be something that they cannot handle, right? So like someone very rightly said, it should be linked to what the students already know or what they are expected to know. It should not be something that is very esoteric and very complex, right? So it should be related to the students' needs. And its questions linked to the case are extremely important, right? And this is also a nice saying. It is frequently more rewarding merely to ask pertinent questions. It may get someone to go and look for an answer. And here again, our emphasis should be on the why and the how questions, because that encourages deep learning. And finally, at the end, once the case is used for teaching or assessment, there should be a review and feedback for improvement, right? So these are the tips that for creating case scenarios. And I've come to the end of my session. And just to summarize what we explored, we looked at the need for case scenarios. There seems to be compelling evidence to show that if case scenarios are included in basic science teaching and assessment, students are able to perform better in the clinical side. Second is, case scenarios can be used very effectively both for teaching and for assessment, both formative and summative. And finally, there are guidelines that need to be followed for creating case scenarios in order to maximize learning outcomes. So if we have time, we can have some questions, else we can conclude the session.
Yes, sir. If anybody wants to have a discussion or questions regarding this, can unmute yourself and ask.
So I'm going to stop sharing my slides.
Sir, somebody has asked you, just repeat the tips again.
I'll repeat the tips, yeah. Okay, so I'll mention them to you. Can you see my screen, madam?
Yes, sir. Yes, sir.
Oh, okay, okay. Okay, so first of all, I think we should learn to work in teams. Okay, so effective cases are created when we work in teams. And as far as possible, try and include clinicians. When we are creating a case for a linker session, it should have multiple components to it. And we should not move from history, physical examination, investigations randomly. It should be logically sequenced. We should understand that the students are in the first year. Therefore, we should not make it too complex. Questions are very important. We should focus on the why and the how questions. And finally, once we do it, we should get feedback from both students and faculty and maybe modify the way in which that scenario was utilized. Is that okay?
Yes, sir. Somebody has asked how many linker cases we can take to the next year.
Okay, madam, I think what the MCI suggests is like a spiral curriculum. I'm going to take the example of anemia. That was one of the linker sessions that was conducted in first year. Anatomy didn't have a role in that. It was mainly physio and biochem. And what the MCI, the erstwhile MCI suggested was that that linker session is progressively used till final year. So in the first year, maybe they just look at certain aspects of that linker session. As they go to the second year, maybe they can look at maybe the treatment aspects. And as they go to the third year, they can look at more complex investigations and things like that. So the suggestion is to use the same linker case and to build it up through the years till the final year. And the examples, there are many examples given in the MCI document. You can please go through that, madam. Typical examples would be myocardial infarction, anemia, maybe for OG, maybe even let's say that postpartum hemorrhage can be used. So I mean, almost any case can be used as a linker. Tuberculosis, right? So maybe even let's say a thyroid condition, thyrotoxicosis. So any case which has sort of broad scope is ideal for a linker session. It should not be too narrow. The link should not be too narrow or it should not be too complex. Okay, in the chat.
And the questions there is there, sir.
Okay.
Once example for case in histology.
Case scenarios in histology. It's a little more difficult, madam, in histology, though it is possible. I can, off the cuff, I can give you an example for liver. What we can do is we can take, let's say, a patient with a cirrhotic liver and put that slide up and give a brief scenario, and then put the normal liver and ask the student to compare and contrast a cirrhotic liver versus a normal liver. So I think that way, it's in histology, it is possible as well. And also, maybe we don't need to go in depth into the pathology component, but at least to see that there's a difference and there's a change in structure. It's certainly possible. Another example is thyrotoxicosis. If we put, let us say, normal thyroid and thyrotoxicosis side by side, they should be able to make out that there's no colloid and the shape of the cells is, let's say, columnar, right? So I think even in histology, we can certainly use case scenarios. Maybe we need to take a little more care there, because we should not go too much maybe into the pathology of it, but maybe just to show that there's a degenerate, that there's an abnormal structure.
And sir, somebody had asked how much of percentage of case scenarios you can include in the assessment.
Yes, whoever asked that, RGHS has set up to 35%, but not all that 35% should be case scenarios. It could be any other, like you don't need to use a case scenario for a higher level question, but you could use. So I think RGHS has set the lower limit, it's a mistake, lower limit at 35%. You can go above that, but what we do here is we limit it to 35%. That's how we do it. I don't think there are strict guidelines as to the exact percentage of higher order thinking questions that need to be included in the question. You have to include higher order thinking questions. There's no doubt about it. RGHS says a minimum of 35%. And of that 35%, again, there are no hard and fast rules. A large proportion of that could be, or at least half of that could be in the form of scenario-based questions.
Yes, sir. We also have designed like 30% should be higher order from our university.
Okay, madam.
Sir, one more question is there. How much CSP from nodal centers has played role in having quality case-based teaching across the nation? Is there any quality check for the same from the nodal center or from NMC or MCI?
No, madam. The answer to that, unfortunately, is no. The role of the nodal center is restricted to making sure that the colleges conduct the CISP. But whether the information from the CISP is utilized by the college to improve the education, no, we are not doing that. Okay, so thank you so much. And once again, would like to thank the organizers for giving me this opportunity. It was indeed a pleasure and privilege. Thank you so much for all your input, and I have also learned a lot. So thank you so much.
Thank you so much for sir taking us through the how to prepare the case scenario. This was actually the challenging for all the especially the preclinical subjects to prepare the case scenario. Thank you, sir, for taking us through the how to prepare and what are the challenges and how to overcome. Thank you, sir. Thank you so much.
Okay. Thank you very much, sir, for the brainstorming session. So now we'll move on to the next session. I request Dr. Najma Mobin, Associate Professor, Department of Anatomy, to introduce the next speaker, Dr. Deepti Shastri. Over to you, madam.
Good morning, everyone. It gives me immense pleasure to introduce Dr. Deepti Shastri, Professor and Head in the Department of Anatomy at Vinayaka Missions, Kirupananda Warrior Medical College, Salem, Tamil Nadu. She has teaching experience of more than 22 years and has held several academic positions. To mention a few, she was the resource faculty, CBME Anatomy since August 2020. She is the member of Board of Studies, Kerala University of Health Sciences since May 2020. She is the Deputy Dean of VMKV Medical College, Salem since November 2019. She is the President, Association of Anatomists, Tamil Nadu since 2019. She is the member of Curriculum Committee, Institutional Ethical Committee, and Academic Coordinator of VMKV Medical College. She has been a resource person, organizer, and moderator for various faculty development programs and webinars related to curriculum implementation. She has published several articles in the national and international journals. She has been conferred with the Best Scientific Concept Paper Poster Award by Father Muller Medical College, Mangalore, and Dr. M.M. Cooper Memorial Award for Teachers by the Association of Anatomists. She has been awarded with innumerable certifications related to medical education and curriculum implementation support programs. With this brief introduction, I humbly request Dr. Deepthi Shastri to help us to enrich our knowledge with regards to the early clinical exposure. Deepthi, madam, please proceed.
Thank you for the kind words you have said about me. I would like to share my slide. Can you see my slides?
Yes, madam. Yes, ma'am, we can see.
Okay, thank you. Good morning, everyone. I would like to apologize for the technical glitch that occurred earlier. At the outset, I would like to acknowledge the management of JSS Academy of Higher Education and Research, Mysore, Dr. Pushpalata, HOD of Anatomy, and Dr. C.S. Vidya, Professor of Anatomy, for inviting me to deliver this talk. Well, what you see on the screen is a scene straight out of any anatomist's life. We put in a lot of efforts to make our students understand anatomy using all the skills that we possess, like this anatomist on your screen. But what goes on in the minds of our students? They think, why do I have to learn this? It is so boring. I thought I was learning to be a doctor. And so medical students join the course with a lot of hope that they'll start treating patients from the day they join medicine. This meme here rightly depicts the life of a first-year medical student. His friends think he takes care of emergency situations like this in the hospital. His family thinks he's doing some hi-fi surgeries. Society thinks he's a noble professional. His teacher thinks he's working hard studying what he's been taught. He thinks he's so like this character from a TV series or any other movie, inspiring a whole lot of other medical professionals. But what does he really do? He sleeps over an enormous number of books. He doesn't have a context for studying, and so has made an entry, the ECE or Early Clinical Exposure module by the MCI. It is a component of the first year of MBBS program, which has been introduced with the objective of providing opportunities to students to develop the ability to learn concepts with their future application. This will definitely generate interest and provide for greater retention and comprehension in the learner. I'm Dr. Deepthi Shastri, and for the next 45 minutes, I'll take you through this ECE module. The objectives of my session are, by the end of the session, you should be able to define early clinical exposure, explain the elements and rationale of early clinical exposure, state the salient principles of ECE, plan the teaching learning methods, including structuring the program, construct formative and summative assessment methods for ECE, initiate capacity building measures for faculty, develop ECE modules for anatomy, foresee challenges encountered in ECE, and plan measures to counter them. So what is early clinical exposure? As defined by Donnan and al. Medical teacher, early clinical exposure is an authentic human contact in a social or clinical context that enhances learning of health, illness, and or disease, and the role of a health professional occurring in early or preclinical years of medical school, usually the first 2 years. This is in Western context. That is why the mention of first 2 years. This is a definition of early clinical exposure by Elizabeth Kay, who says, early clinical exposure is a teaching learning methodology which fosters exposure of the medical students to patients as early as the first year of medical school. ECE acts like a bridge between preclinical disciplines and clinical disciplines. So, what constitutes early clinical exposure? Students learn both basic and clinical sciences using integrating learning activities such as early contact in hospital or community settings, communication skills, problem-based sessions, etc. ECE enriches and contextualizes the learning of basic and clinical sciences and offers a wide variety of teaching learning methods. Why is early clinical exposure necessary? Well, the students look forward to dealing with patients and learning how to take care of them in phase 1 MBBS itself. And I'm sure all of you have experienced this kind of a case scenario. Preclinical experience, however, is far removed from the purpose why they have entered medicine. It is difficult for them to correlate the structure, function, and metabolic processes without seeing patients and understanding the purpose of what they are learning. They expect to see patients from day one, but what they are exposed to are dead bodies, cadavers, and dead tissues that they see under the microscope. So what are the elements and rationale of early clinical exposure? It enables the learner to recognize the relevance of basic sciences in diagnosis, patient care, and treatment. It provides a context that will enhance basic science learning. Authentic human contact enables the learner to relate the experience of communicating with the patient, which can be used as motivation to learn. The introduction of humanities in medicine helps them to recognize attitude, ethics, and professionalism as an integral part to doctor-patient relationships. And they understand the socio-cultural context of diseases through the studies of humanities and medicine. Next, let us move on to what are the salient principles of early clinical exposure. The principle of early clinical exposure is it helps them to provide a clinical context and patient centricity. Clinical context should preferably be with the presence of actual patients, but clinical context can include case scenarios, which can be paper-based, as Dr. Nachiket has already discussed in the earlier session. It could be in the form of videos, simulated patients, or investigation reports. The purpose of ECE is, however, not to prepone clinical teaching, but to provide better understanding of basic sciences through a clinical context. I noticed some of you have mentioned earlier, like Dr. Ramani T has posted that they will remember the clinical cases rather than the basic science. So that should not be the objective of conducting early clinical exposure. Now, where do we use ECE? It is advisable to expose the students to clinical context in various settings. And as you can see, there are three settings that we can expose the student to. One is classroom setting, the other is hospital setting, and community setting. In classrooms, case discussions can be encouraged with the patient being brought to the classroom for an authentic human contact. In hospital setting, students make hospital visits and are exposed to patient care by healthcare professionals, including paraclinical staff like nurses, physiotherapists, healthcare workers, etc. In community setting, the students are exposed not only to the patients, but to the social conditions, economics, status of the patients, also the community. So, in all the three types of settings, the students can acquire basic clinical skills and can be demonstrated clinical problems. However, the context to their learning should always be the focus. Earlier, I noticed an anonymous attendee had posted during Dr. Nachiket's session that the teacher should remember may not remember clinical anatomy over a period of time, but they can have consultations with the clinicians, and the context, however, will always remain anatomy rather than the clinical case condition. The other thing that we should focus on is the relevance of the clinical case to basic science, which has to be emphasized. So it is not the clinical case that is emphasized, but the basic science relevance is emphasized. Going back to the MCI GMR 2019 recommendations, the time allotted for ECE in the first year is 90 hours, which is equally divided amongst the 3 preclinical subjects. So the total number of hours available for anatomy is 30 hours, which is further divided into 18 hours for basic sciences and 12 hours for clinical sciences. And each of these needs to be a 3-hour session, preferably, and conducted once a month for 6 months for basic sciences and once a month for 4 months for clinical sciences. In case of basic science correlations, which are up to 18, actual patient contact, or it could be in the form investigation reports or have a paper-based case. Dr. Nachiket has already described how cases need to be developed. So this is just a case. I'll just read it out to you. A patient was admitted in the medicine ward for fever lasting for more than a week. A blood test was advised by treating physician. While drawing the blood sample from the median cubital vein, the trainee nurse observed that the blood in the syringe was bright red. She immediately withdrew the needle and reinserted the needle slightly medial to the previous puncture site. The patient now complained of sharp pain radiating to the lateral 3.5 fingers. So what the student needs to know is, first of all, identify the procedure being described in the case. And then there would be anatomy questions in relation to the case. Like, for example, name the superficial veins connected by the median cubital vein, name the artery which is punctured in the case study, name the nerve which was irritated by the needle. So these are examples which we use in our institution. Now let us move on to clinical skills. Clinical skills meant to be for 12 hours, 3 hours per month for 4 months. Clinical skills can be demonstrated by either a preclinical faculty after a session of consultation with the clinicians or by the clinicians themselves. The students need to experience clinical skills in human context, and they could be divided into small groups if feasible, and they should possess observation guides or checklists. Cases can be demonstrated in wards, OPD, or in demonstration rooms. In case a patient is missing, absconding, or you have planned a session, ECE session with a particular case, but there is no case available, in the hospital, then you could probably use videos like this. Is the sound audible?
Yes,
Hello,
ma'am.
my name is Andrew. I'm one of the
Okay,
final
thank you.
members.
Fine.
Just confirm
Audible,
your
ma'am.
age,
Thank
please.
you.
Hi, I'm Simon and I'm 24 years old.
Nice to meet you, Simon. Today I've been asked to examine the thyroid gland in your neck. Would that be okay?
That's fine.
This will just involve me generally inspecting, then I'll move in closer to the neck to have a closer look, and then have a feel of the neck as well. Is that all right?
Sure.
That's great. Are you comfortable where you are?
Yeah.
Fantastic. We'll start. Simon, if you could just bring your arms out in front of you like this and splay your fingers. Fantastic. I'm just going to lay a piece of paper on the hands. If you could turn your hands over for me. Finally, I'm going to feel your pulse. Thank you. I'm now going to look more closely at your eyes. If you could just pick a point on the wall behind me. And now I'm just going to look from the side. And I'll now look from behind. If you could just look slightly up for me, Simon. We're just going to do some movements of your eye now, Simon. So if you could just follow my finger, do let me know if you have any pain or double vision. That's great. Again, if you could keep your head still and follow my finger for me. Thank you. I'm just going to more closely inspect your neck now. If you just stay as you are. And if you could just take a sip of this water and hold it in your mouth. And swallow. Fantastic, Simon. If you could just stick your tongue out now. And I'm just going to feel your neck as well. If you could just stick your tongue out for me, Simon. That's great. And if you could just take a sip of the water for me. And swallow. I'm just going to feel the glands in your neck. Fantastic, thank you. I'm now going to feel your windpipe. It might be a little bit uncomfortable. I'm now going to tap on your chest. Finally, I'm going to listen. If you could just take a deep breath and hold your breath there. and breathe normally. Simon, I'd just like to finish with some special tests. So we're going to start with the reflexes in your arms. If you could just relax your arms on your lap like this with your palms facing to the ceiling. Fantastic. I'd just like to look at your shins, if you wouldn't mind rolling your trousers up for me. Sure. Fantastic. And finally, if you could stand up, but first I'd like you to cross your arms for me. And relax. This completes the examination. Thank you very much. Today I examined Simon Sayers, who's 24 years old. On general inspection, he had a fine tremor of his outstretched hands, but there were no other peripheral stigmata of thyroid disease. There was no evidence of thyroid eye disease and no goiter. To complete my examination, I'd like to do some blood tests and look specifically at the T4 and TSH levels.
So in this case, which is related to thyroid gland, the student gets to observe professional attitude of the doctor or the doctor student, as in this case. He gets to see how he communicates at each step with the patient, how movements of the eyeball are tested, how the patient is asked to swallow by sipping water to look for movement of the thyroid gland on deglutition, how he asks the patient to put out the tongue to look for movement of thyroglossal cyst, why the extent of lobes of thyroid are important, how a retrosternal goiter is identified by percussion, how the thyroid gland is auscultated for thyroid buruing, how to look for enlarged lymph nodes in the neck, and how to look for trachea. So the onus of developing ECE is on the faculty, and the points to consider while planning ECE are: what is the student being asked to observe? What prior knowledge does the student have? What might he learn from these observations? And so we need to develop observation guides. We need to give instruction on what he should watch for when the doctor examines the patient and see, in this case, it is a case of thyrotoxicosis, to see if he can identify any typical features of thyrotoxicosis, reflect on basic signs correlation between his presenting symptoms and signs. Observation Guide 2. Before I go on to Observation Guide 2, I'd like to mention that the MCI booklet has given an annexure 2, which gives how observation guides could be developed. Observation Guide 2, where the student can be asked to watch as the doctor demonstrates how to ensure it's a thyroid swelling, how to palpate the thyroid gland, and correlate the method of palpation with the anatomy of thyroid that he has learned. To add communication skills or affective domain, he needs to watch how the doctor communicates at each step with the patient. The preclinical faculty should keep in mind that debriefing is essential after every session. And what goes into debriefing? The student has to reflect on how he feels after the ECE session. What happened during the ECE session? What did he learn? And how does this relate to the learning of anatomy? And what if he has learned a clinical case? What next? How is he going to use this knowledge in learning basic sciences? Next, we move on to how to plan conducting ECE. Planning is warranted for conducting any new teaching learning methodology. Now, a 3-year ECE session can follow the following guidelines. Introduction to the specific module and instructions for the session can be delivered by preclinical faculty for about 30 minutes. This is followed by clinical experience in any of the setups mentioned earlier, classroom, hospital, or community setup. Here, the student needs to carry observation guides or checklist, and this session can last for 1.5 hours. This is followed by summary and conclusion, in which learning points which can be elicited from the students by the faculty by posing review questions, so that the students are engaged till the end of the session. And this can last for another 30 minutes. Next, I would just like to introduce you to a component of ECE, that is Humanities and Medicine. The competency addressed by introduction of Humanities and Medicine is the learner must explore, discuss, and reflect on human illness, suffering, and medicine as portrayed in literature, either classic or contemporary. The MCI ECE document does make a mention that it is merged with ADCOM, and there is no specific time allotted for humanities in ECE, the 30 hours specified by MCI. But I would still like to add a few slides on humanities and medicine. This is a book called as Gifted Hands, which is penned by a prolific pediatric neurosurgeon, Dr. Ben Carson, who works for Johns Hopkins University. This book takes you through the trials and tribulations he went through from his poverty-stricken life to the success that he is today. Atul Gawande is a surgeon who is a prolific writer once again, and he has authored many books. And in this book called as Being Mortal, he discusses end-of-life care and death with patients. I'm sure all of you are familiar with When Breath Becomes Air, which is penned by Dr. Paul Kalanidhi, an American neurosurgeon. It is a memoir about his life and his illness, that is metastatic lung cancer. I'm sure you must have watched Patch Adams or the Indian versions, Munna Bhai MBBS, or the Kannada version, Uppi Dada MBBS. Movies like this, or My Sister's Keeper, which actually talks about this girl who has to donate her bone marrow to a sibling against her will. So she resists the donation of her bone marrow without her will to her sibling. There are other serials like The House or Grey's Anatomy or the Korean drama like Doctors. Now, all these movies, books can be used as resource materials for students to finally reflect on and pen their narratives. In our institution, we have developed an innovative method of narrative-based education called as Fresh Notes for Interns. And we use all these movies and scenes from the movies for them to learn the subject of medicine, not just anatomy. It could be any subject from medicine, surgery, physiology, any subject. Okay, not just movies, but paintings as well. Frida Kahlo, I'm sure the new generation is familiar with, as mementos of Frida Kahlo are the in thing with the current generation, the ladies especially. So it is not just movies, but paintings also inspire study of anatomy. Now, Frida Kahlo, The Forgotten Medical Student, is a book, and the author, Antello, he discusses Kahlo's interest in medicine and the detailed illustration of anatomy and classical genetics in her artwork. Moreover, the discussion explores the numerous medical conditions of Kahlo and how she created a visual record of health through her paintings. The medical condition that Kahlo suffered is she was afflicted by polio in 1913. and had limb and spine deformities. She is very well known for her artwork, which include illustrations of anatomy. Rudyard Kipling and his 6 honest serving men, what, why, when, how, where, and who. These are the favorite of all of us who have read Park and Park, the PSM textbook. How can we forget the quotes and poems dedicated to anatomy in B.D. Chaurasia's textbooks of anatomy? इन्हीं के कारण तो anatomy पास हुए, ग्रे के चक्कर में तो निपट जाते. And of course, Leonardo da Vinci. So humanities and medicine give us ample opportunity to explore the human side of the practice of medicine. Okay, now coming back to ECE, Dr. Nachiket mentioned 2 terminologies. One was basic science correlation in ECE, and the other was linker session. So let us see how ECE can be related to integration and at what level of integration ladder it stands. I'm sure all of you are familiar with this table, which is in the alignment and integration module of the MCI document. There is this term called as nesting used in this document. Nesting is something that we do all the time. That is applied anatomy. We keep introducing clinical sciences into basic science teaching as applied anatomy in most of our classes. Now, where does ECE stand in the ladder of integration? It lies at the level of correlation. And as Dr. Nachiket mentioned, early clinical exposure can use these linker sessions. Now, I think all of us have been developing ECE modules with anatomy and clinical subjects. I wonder if any of you can share your views in the chat section. I will look into the chat section at the end of my presentation. I would like to know if any of the institutions have linked all the 3 basic science ECERs with clinical sciences. In our institution, before implementation of CBE, the last couple of years, we have been conducting a program called as Win Med Mantra, which includes using linker sessions for all 3 preclinical subjects and linking it with a case study. And earlier during Nachiket's session, one of the faculty had actually posted in the chat section as to whether the clinical cases are gone through by the CISP, conducting nodal centers or regional centers. Well, maybe they need not be involved, but our own preclinical faculty can discuss the case with each other, develop it on the table, as Dr. Nachiket put that picture, and they can consult the clinician and validate the case that they have developed. So we had this kind of sessions earlier where all 100 students were exposed to link. We have 100 admissions, so all 100 students were exposed to a single linker session where they did not have to go to the hospital for an authentic human contact, but used a paper-based case to link and create an ECE module. Next is assessment. As assessment drives learning, early clinical exposure also needs to find a place in assessment. Dr. Nachiket has mentioned, so I will go a little quickly through all these. Formative assessment can be involved in ECE assessment by periodic assessment of logbook entries by the students. Also, assessment of the portfolios that can be maintained by students. Now, it is suggested by MCI that internal assessment exams as well as university exams must include elements of ECE to test the ability of students to apply basic science knowledge to clinical context. Hence, the type of questions that cater to the aspect of ECE are problem-based long answer questions, clinical VNA-based short answer questions, problem-based MCQs, and practicals being tested by objective structured practical examination. These are some of the examples I'm posting for MCQ, for short answer question and long answer question. Due to paucity of time, and since Dr. Nachiket has already dealt with it, I'll not read the case scenarios. This is a clinical condition of myocardial infarction, which can be used for OSPE. The case scenarios used for short answer questions and OSPE may be similar to each other, but in OSPE, elements of practicals come into play. Since this is a case of myocardial infarction, the questions that can be asked are which blood vessel is affected in this condition, what is it a branch of, what is the area of its distribution, and how is cardiac dominance determined, and what type of dominance is beneficial to patients. Now, this could be a response station, and it could follow a procedural station where a specimen of heart could be placed, blood vessels can be tied, and the students can be asked to identify the blood vessel, or no need to tie, the student can be asked to point out in the presence of an observer which blood vessels supply the heart, and to trace the blood vessel from the origin to termination. Again, some of the faculty during Dr. Nachiket's session, I noticed that they were suggesting that the faculty need to be trained. So how do we achieve capacity building for faculty? Preclinical faculty and clinical faculty must plan in tandem with each other. And the training should be not only to help the preclinical faculty to develop the ECE modules, but also train them on implementation and also help to make them create problem-based questions for assessment. Now, how do we implement or monitor ECE implementation in the institution? It is done by curricular governance with the dean as the head of the proceedings. He needs to oversee all the proceedings overall. Under him is the curriculum committee, which consists of 6 members, 1 representative from preclinical, 1 from paraclinical, 1 from the medical education unit, that is the coordinator, 1 representative from medicine and allied health sciences, and 1 representative from surgery and allied sciences. Under the curriculum committee is the curricular subcommittee, which consists of the head of the department and a few other working members from each of the preclinical departments, the medical education unit, and the heads of the departments themselves. Now, what is the function of each of them? The curriculum committee can initiate ECE, curricular subcommittee can implement, medical education unit can monitor. Medical education unit and the heads of the departments need to coordinate with each other. Now, the most important I consider for conducting integration or early clinical exposure modules is the topic team. The topic team members include a working group that can coordinate to develop linker sessions or work out the logistics like availability of patients, clinicians, charts, X-rays, or other clinical material for conducting the sessions. Next, let's move on to designing the ECE module. All the content that I've taken is from the ECE module of MCI. So first, what you need to consider is what is the setting, hospital, classroom, or community setting. The learning objectives need to be stated. Learning experience need to be planned. Planning of implementation has to be done. The challenges faced and the measures to overcome them need to be discussed. And finally, the ECE module needs to be evaluated. So planning needs to be done for evaluation of the ECE module. Now, this is the annexure 4 in the ECE module, and it gives a designing of an ECE module for varicose veins. You can have a look at it later. This is a format for designing ECE modules that has been shared by the nodal centers. So what is left to us anatomists is we need to develop observation guides before we send students into the hospital setting. Now that we have seen how an ECE module can be designed and how it can be implemented, let us see what are the challenges which are encountered in implementing ECE. So one of them, like Dr. Shushant mentioned during Dr. Nachiket's session, that time constraint is one of the challenges. So it is a time-consuming event. More manpower is needed. It is resource intensive. You need patients, charts, x-rays, investigation reports, and so on. It cannot be applied to each topic. I noticed Dr. Atul Antony had mentioned that the students need actually to learn the ABCD of medicine, that is anatomy, before they go on to clinical cases. So we need not apply ECE for every topic. And academically weak students may not live up to expectations of an ECE module. Coordination is needed with supportive clinical departments. All of you will agree with it. We may have uncooperative patients. Identifying clinically relevant core content and framing its learning objectives requires training of faculty. Extra efforts are needed by faculty. For these 2 points, I think the curricula subcommittee can take over and ensure that training of faculty is achieved. Now, confusion may lie in the minds of students as a disease can affect multiple systems at a cellular level. But we might have sent them to just look at one particular system or one particular organ. Now, how do we encounter or counter all these challenges? Efficacy of ECE can be increased by adopting hybrid method. Entire syllabus need not be covered, but restricted to a few common clinical conditions. With COVID-19 pandemic, we have had one more new challenge because we resorted to online education. So hospital setting, classroom setting, or the community setting was all thrown out of the window. So how do we counter this? So what we did in this situation is we again created videos because the faculty were present in our hospital. So we decided to create some videos. So I'll just show you a glimpse of a video we created. Sorry.
Hey there, this is Dr. Rajita. Welcome to our learning platform. Clinical skills are significant in medical practice. Learning these clinical skills in a right way will help in treating the patient and avoiding complications. So, urinary catheterization is one among the basic medical clinical skill. And simple things, if they are ignored, may lead to larger issues. So today, I am happy to introduce Dr. Melvin Dominic, emergency physician, who is going to demonstrate urinary catheterization for all of us.
Because of time constraints,
and it is important to check for the date.
Go further. This was about urinary catheterization, and the catheter, how to be introduced in a mannequin, was
After
demonstrated
emails,
and recorded.
Bye. Take care.
So these are the challenges faced and the measures taken to overcome the challenges. To summarize, ECE is a teaching learning strategy where the clinical content is introduced to enhance relevance and understanding of basic science subjects. Students are motivated to learn with deeper understanding of the subjects and develop problem-solving skills. And as Dr. Nachiket also mentioned, we would like all of you to share your experiences. And I would like to end with a quote by Dr. Munira Hirakani, who says, "Many ideas grow better when transplanted into another mind than the one where they sprang." So let us keep sharing best practices with each other. Thank you.
Thank you, ma'am. Ma'am, there's a questions in the
Yes,
question
ma'am.
box.
Yes,
How to
ma'am.
carry ECE in online mode?
I think I just answered that question as well. Authentic human contact may be an issue with online learning. Otherwise, videos can be posted. And what we did is our students were exhausted with all the online teaching that was going on. So since we had already taken ECE sessions and the students were aware on how to conduct ECE modules, we asked them to do peer learning. We asked the students themselves to create videos. So they use their family members or their friends to create videos where they could demonstrate. They were like simulated patients. So they could demonstrate, communication skills and attitude and so on. The other one is, as I showed you, clinical skills. We created videos using audios in our, mannequins in our clinical skills lab. So these are two of the solutions that I can think of.
Ma'am, another question is how to assess the 150 students after ECE sessions other than MCQs?
Okay, for this, what we did is we asked the students to write their reflections. So other than MCQs, you can ask the student to write reflections. We can create rubrics, train the faculty on how to create rubrics to assess reflections. Now, of course, with online learning, all of us have become very familiar with Google Forms. So they could write their reflections on Google Forms and it would be easy to correct them as well.
Yes, ma'am, agree with you. The reflections, reflective writing is the best practice I feel you can introduce with that. Now, one more question is, what about the skills domain with respect to online learning? How can you ensure it?
That is the biggest challenge all of us agree we have. Even for clinical, forget early clinical exposure. You can imagine the pre-final and final year students who are stuck at home and are unable to undergo clinical training. That is why the MCI recommends that after the lockdown is lifted, the student need to be present in the institution and learn the clinical skills in person. Medicine can never be an online course. Medicine has to be learned with authentic patient contact and clinical skills need to be learned with the patients. So that is a challenge. Online learning, clinical skills, teaching as well as assessment.
But one more question is there. Do you feel asynchronous or synchronous EC would be better in online platform?
Okay, with synchronous, the main problem is internet connectivity with students. I'm saying this in relation to in terms of the connectivity that the students have in remote areas. So we need to consider all the students. If synchronous is possible, that synchronous would be the best. But what we have noticed during this time is that there are a number of students who have internet issues and asynchronous would be fine. And it could be preserved in their repertoire also. Repertoires can be maintained. ECE modules can be maintained by them. So I guess both would be depending on what is the convenience.
Ma'am, one more question is there. Whether after taking ECE session, any change in the knowledge or skills in the first years?
Well, it's too early. I think a longitudinal, assessment of the students needs to be done. What we would be testing is immediate knowledge. I think the way we teach basic sciences, like one of them actually mentioned, like Deepa Bhatt, I think Dr. Deepa Bhatt had mentioned, we had created good doctors earlier. So how do we know whether ECE has made a difference? I feel we need to do an assessment when they are in the second year, pre-final year, when they reach internship, and maybe, that Kirkpatrick's level of assessment of their skills needs to be done. So it's a longitudinal program, according to me.
I think somebody has raised, Dr. Nagashri. Have any query? We have unmuted you. Please, you can ask.
Dr. Nagashri? Nagashri MB?
Yeah, ma'am. I'm there.
Yeah, you can ask.
Ma'am, no queries. It is a very nice presentation, ma'am. Very informative presentation. Thank you, ma'am.
Thank you, ma'am. I see Dr. Deepa Bhatt has posted another query. Are there any ethical issues involved in sharing clinical details in social media platforms? There are definitely issues, ethical issues, if the patient identity is not maintained on social media platforms. In fact, we take an undertaking from the students right at the beginning that they are not to share even cadaver pictures on the social media platforms. So we need to restrain ourselves while posting. I do see a lot of doctors posting their patient pictures on Facebook. I don't think that is very ethical. Patient consent needs to be taken before any kind of publication is done. Any other questions, ma'am?
No, ma'am. Anybody else who wants to raise their question? Yes, ma'am. I think you have answered all the queries. Thank you very much, ma'am, for taking us through the early clinical exposure, which was needed for all the preclinical faculty, how to go about. You have said all what are the necessary and how to conduct EC also. Thank you very much, ma'am.
Thank you, ma'am. I would like to thank you, Dr. Pushpalata and Dr. C.S. Vidya once again for inviting me to present this talk. Thank you. I would like to thank all the participants for their questions and their patient listening. Thank you.
Thank you very much, ma'am, for the wonderful session. It was enlightened us about the ECE. Now we'll move on to the next session. I request Dr. Hema Malini, Associate Professor, Department of Anatomy, to introduce the next speaker, Dr. Meenakshi Swami.
Thank you, Dr. Vinita. Seeking the blessing of His Holiness, good afternoon to one and all. I am honored and privileged to introduce our next speaker, Dr. Meenakshi Swami. Madam completed MBBS at KIMS, Bangalore in 1999, MD Anatomy at St. John's Medical College and Hospital, and was awarded second rank by Rajiv Gandhi University of Health Sciences. Postgraduate certificate in clinical education at Newcastle University, UK in 2010 with a merit in the principles and practice of teaching module. Madam is Fellow of Higher Education Academy in UK since 2010. Madam is Director, Trustee and Deputy Secretary of the British Association of Clinical Anatomists. Madam is registered medical practitioner in UK and has worked as doctor at hospitals both in UK and in India. Currently, Madam is working as lecturer at Newcastle University since 2018 and was previously as assistant professor at Durham University. She has also worked in anatomy department at St. Christopher College of Medicine and St. George University Hospital in UK. Madam has undertaken a full range of anatomy teaching across medical and other healthcare programs at undergraduate and postgraduate levels. She has received Excellence in Teaching and Learning Award at Durham University and Teaching Excellence Awards nomination at Newcastle University in 2019. Madam has been the Associate Director of the Center for Medical Education Research at Durham University. Her research interests are anatomy, pedagogy, medical education, and clinical anatomy. She has numerous presentations at national and international conferences and publications. And Madam has conducted workshops at British Association of Clinical Anatomists conferences on improving medical education with innovative ultrasound and clinical education. Madam is also Associate Editor of BMC Medical Education Journal, Reviewer for Clinical Anatomy, Anatomical Science Education, Annals and Bulletin Journal, Health and Social Care Education. Over to you, Madam.
Thank you for the introduction. And it is a great pleasure and privilege to be sharing my experiences with you all. And I would like to greatly thank JSS Academy for this opportunity. I'm going to share my screen. Can you all see it?
Yes, madam. You can see the screen.
Okay, I'm going to be talking about assessment tools in anatomy for competency-based medical education. So I'll start by briefly talking about purposes of assessment and how anatomy is taught in the UK, blueprinting, and then move on to anatomy assessment methods and our review processes. I'll also briefly talk about characteristics of assessment tools, and finally about the standard setting process we follow, and we'll share some examples of good practice. So first of all, to begin with, what is assessment? So it's biopsy of knowledge and skills, which is equivalent to clinical competence. So when we are assessing anatomy or any other subject, we need to know or consider why we are assessing, the purpose, what we are assessing, the competence, and how are we planning to assess. What are the available tools or methods that we can use to meet the whys and the whats? And not to forget the context in which we are assessing. Now, traditionally, education was teacher-centered with discrete outcomes. So students would gear towards scoring highly in their exams. Now, we are moving on to other models of teaching and assessment methods, reflecting modern educational frameworks. So that would be competency by design, which greatly focuses on how we can support students, how we can support their learning, for them to be able to retention all the learning that they have previously, how to help them integrate their knowledge, and how to transfer this knowledge from the classroom setting when they move on to clinical practice. So there is more emphasis on formative assessment, providing guidance positively to students, giving them feedback on their learning needs, to motivate them, to make them lifelong learners, which is very important. And these are the goals for formative assessment, where the students are not worrying about passing or failing. Instead, they want to accumulate their experiences in order to progress as competent and safe doctors. But we also need to assess them, determine their progression year after year, and ensure that when they qualify, they meet a minimum standard. And there is an element of ranking where we need to discriminate between students who perform highly and those that are average performers and those that are below average. Now, for qualification, where we want them to be competent enough, the assessments are designed to be sensitive at the borderline between pass and fail. Whereas to discriminate, they are sensitive where most candidates are found, that's the middle of the range. Now, assessment also provides feedback on staff, on their student performance, and also lets us know how successful is our course. GMC is equivalent to MCI, so that's General Medical Council. So the GMC sets out the standards and requirements for all stages or all years of medical education, right from year 1 to year 5, and training in the United Kingdom. Recently, there has been Outcomes of Graduates 2018 document, which lists all the learning outcomes, and the overarching outcomes would be professional values and behaviors, professional skills, and professional knowledge. Anatomy comes under professional knowledge and belongs to applying biomedical scientific principles. So what we have here is the students must be able to apply their biomedical scientific principles. So in anatomy, they need to explain how normal structure and function and physiological processes applies. So they're talking about integrating these into the patient care. So the emphasis is on integration of clinical and basic sciences and application of anatomical knowledge in clinical context. So competency-based medical education is an outcome-based approach using an organized framework of competencies that are required for safe and effective clinical practice. Now, in the UK medical schools, there is no prescribed learning outcomes in anatomy, as you all have from MCI. So UK medical schools determine their own curricula and their own method of assessment. So the anatomy curricular content varies widely at medical schools. So some medical schools adopt a system-based curriculum, some adopt region-based, some adopt case-based, and some problem-based. So at Newcastle University, we moved 3 years ago from a region-based anatomy to case-based anatomy. Now, anatomy is taught along with the other components for the first 2 years of medicine. So all basic sciences are covered. That's including pathology, pharmacology in the first 2 years. And then they move on to clinical rotations from year 3 onwards. So what we have in case-based curriculum is we've got around 25 cases which run for a period of 2 years. So for example, I'll give you the brief description of the case that I lead, which is a trauma case. So what we have, as Dr. Nachiket mentioned, is a team which writes the case. So 3 years ago, there was a team which was formed and which involved clinicians and also the case leads who may or may not be clinicians like myself, who's a clinician but is into academia. So we needed to create a team to write these cases. So one of the GP practicing clinician, that's a general practitioner, what we call in the UK. They wrote the basis of the case, and then this was discussed with the orthopedic surgeons, A&E consultants as well, as to how this case needs to be. And it runs for a period of 3 weeks where we teach anatomy of the limbs. So upper limb and lower limb anatomy is taught in that period. So there is also communication skills, wherein students learn how to take a history all along 2 years. So right from the case 1, so that's from the first few days when they are into the curriculum, they start learning how to take basic principles of how to take a history. And there's also clinical skills. What Dr. Deepti was showing, like a video about the ECI, early clinical experience, what students have. Here in the UK, they also perform basic clinical skills such as examination. So in the trauma case, what we had to do is we had to organize anatomy when it is relevant. And then there is pharmacology taught. There's also many other things. So it was a team. So establishing a case was a team approach, team-based approach. And there were certain learning outcomes that needed to cover. Now, again, we're talking about asynchronous and synchronous now because of COVID. But even before that, when we had to launch this case, we had to ensure that not everything can be taught in the given time. So students had to own up as adult learners. They had to learn about how it is to be able to self-learn some of it. And then when they come to the teaching sessions, they can then interact with the person teaching. So there had to be a balance between SDL learning outcomes and or taught learning outcomes. Moving on. So when we consider anatomy and competence in anatomy, students will have to know the facts and how they apply these facts in clinical reasoning. Now, anatomy is also required when they perform clinical examinations, when they perform clinical procedures. It is one of the important cornerstones of medicine and is actually essential to interpret images. Now, communication skills, yes, when you are interacting with patients, communication skills is essential. Having the right attitude. In anatomy, I think we incorporate some amount of professional behavior as they enter the dissection room from year 1, where they have to show utmost respect to the cadaveric material that they are learning from. So there is an element of professionalism as well. Now, Dr. Nachiket has already mentioned the model of clinical competence, which enables professional authenticity as students move up from nose at the bottom of the pyramid to DUS at the top of the pyramid. So when they begin, they are at the bottom of the pyramid. They're trying to learn things, all factual things, and they're trying to apply this factual knowledge. So that's knows how. And these can be assessed as computer-based or written examinations. Now then, during the clinical years, as they move on, they do perform or hands-on experience. So they meet patients and they are assessed with respect to skills and attitude. However, most of the UK medical schools, they start moving up the Miller's pyramid into skills, and they assess clinical skills of their students. So the assessment tools for knows and knows how, which are commonly used for recalling factual knowledge, would be single best answer, which is a better form of multiple choice questions, extended matching items, short answer questions. And similarly, these tools can be used for students to provide contextualization of the knowledge. So it's applied anatomy that we test in knows how. And we also test them with respect to OSCE, which is objective structured clinical examination, and use simulators or simulated patients earlier on in the first 2 years before even they have moved on to clinical rotations. And when they move on to clinical rotations, they'll be in the shows how and does, where they move on to performing these skills on the patients, where they then are assessed how competent they are, and work-based assessments also inform them. So anatomy assessments can be classified as written examinations, which I've already mentioned. So that's MCQ, EMI, SAQ, and essays. And there are practical examinations, which are OSCE, spotter exams, OSPEs, and Vivas. Now, general medical that we use a range of assessment techniques. So there has to be multiple objective measures. So objectivity is when we don't use subjectivity. So when many of us mark exam papers, we are going to be bringing in some subjectivity, which is what the recommendation is to avoid those kind of subjectivity and to ensure some kind of objectivity. Now, the characteristics of good assessment tools. So they have to be valid. Does assessment measure what it is supposed to measure? So we've got face validity. So does it look appropriate to experts? Content validity. Does it represent the domain being tested? Content validity. Does it respect the domain being tested? Construct validity. Is there a relationship between the test and some underlying intellectual construct, such as exposure to teaching, student motivation, and intelligence? Now, the next characteristic is reliability. So we have to ensure that assessments are reliable. So the question to ask is that assessment measures, are they consistent? So if the student took a similar test on 2 occasions, would they get the same outcome? Do different assessors of the same thing agree with each other? Now we've got statistics which help us with this, and Cronbach's alpha or KR20 are used as measures of internal consistency, and they range from 0 to 1. Now, the next thing to consider is the cost effectiveness and then acceptability. So are we able to accept a form of assessment? Now, teaching and learning activities are designed to meet learning outcomes, and assessment content should match the learning outcomes. So there is a link between teaching and learning and assessment. So if you're not teaching in a clinical context, it is not fair to students to be able to assess them in clinical context. So teaching and learning and assessment go hand in hand. So staff are encouraged to plan assessment, plan writing questions as they're planning their teaching sessions or teaching material as well. So how do we decide what to test? I'm sure most of you agree with me that blueprinting is very, very useful. So sampling should be representative of the course, but important items should represent a larger proportion of the assessment. So you might realize that it's not possible to test all the learning outcomes in a given exam. So an attempt should be made to assess as much as possible in a year with multiple assessments. This could include formative as well as summative. The things to consider while creating blueprinting is we need to be aware of the learning outcomes. We need to take account of each of the learning outcomes. Then proportion of the assessment dedicated to particular domain should be decided. Now, we have to also consider what would be the most appropriate assessment to use for a particular set of learning outcomes. Calculate the duration. So how long are we going to test them? How many items or questions to include? Now, this is an example of a blueprinting. Now, the axis which is recommended usually is the subject needs to be on the left side of here, the column, the first column, what you can see. So that's the y-axis, the topics, or you can list each of the learning outcomes in each of the rows. But I would do that separately to keep them consistent, or it's much easier as well while calculating. And sometimes we tend to use different blueprints to calculate different things. So here I've used this blueprint only to calculate the number of questions. Now you can see the x-axis here can be used to note down the types of assessments or modes of skills that we are assessing. And you could either calculate the number of hours taught or the number of learning outcomes. I've had the experience of doing them both. I think the number of learning outcomes is much easier. Now here we take the percentage of, so the 22 on the first row of the last column, what you see is the percentage number of hours that's been taught or calculated. And then the next step would be to decide how many questions are we going to include overall in an exam and each of these exams. So DIPSI is data interpretation short answer exam. So that's in the first column, as you can see. And if that's 200 marks, you can allocate 20% of the assessment questions to be allocated for a short answer paper. And then what you're seeing here is a divided number, so 45%. So that's 10% of the marks, and these two would be 45% of the marks. Now, again, there needs to be a team which decides with more senior members of staff as to how many questions we would like to ask in each of these exams. And once you decide that, it would be pretty much the same, you would review it, but changes to that would not happen for a long time. It needs to be updated though, but overtly changing it doesn't usually occur. And after that, we then calculate the proportion of questions for each, say that's respiratory system, GI system, based on whether you teach system-wise or region-wise, list the learning outcomes and calculate as to how many questions for each of those. So what we've done here in red is once we've calculated that, we've then gone on to obtain 10% of the overall questions for each of the system. And then these two columns will be calculated as 45%. Now the next question is how to construct texts of knowledge within a clinical context. And
Dr. Meenakshi, just
Yes.
one question. Somebody's
Yes.
asked, can you just explain what is SBA and EMI? Because it's there in the blueprint.
Oh, yes,
They'd like
sorry.
to know what is
Sorry.
SBA and EMI? Yeah.
Yes, yes. So a single best answer, an MCQ, we'll come to that shortly. My next few slides will explain that in detail. But MCQ is multiple choice questions. And we move towards SBA, or single best answers, which is a better form of assessing, especially with clinical contextualization. And EMI are extended matching items. And I will describe these assessment methods shortly. Yeah, so regarding constructing texts of knowledge, I think Dr. Nachiket has very beautifully taught us how to construct case scenarios within the teaching and assessment areas. Now, MCQs tests knowledge recall, so that's knows. It has a short lead-in question and 4 or 5 answer options. Okay, that's something I'm sure we are all familiar with. But SBAs, which are single best answers, tests application of knowledge. So it's going, if you remember the Miller's pyramid, it moves up the pyramid to the next level and is testing application of anatomical knowledge. So there are 3 things what are essential. Now, there needs to be a STEM, which is a case scenario, describing a case, a problem of a situation, with short and precise leading questions. Now, the university is very keen that we do not include a lot of description, especially in assessment, because there will be students with disability who may not be able to read and understand the question well in the given time, although they are given extra time in their examination, but still we would want to include a STEM or a description of a case or a problem of a solution, which the students need to answer the question. So if there are bits included just for developing the case beautifully, we wouldn't encourage that in assessment. Yes, it's very good formatively for formative teaching and assessment, but not for a summative where it's pass or fail for the student. It's high stakes exam. Now the options should all be possible solutions or responses to the question arising from the STEM. So what we encourage question writers is to include incorrect options which are not totally wrong. It is very challenging in anatomy to develop such questions, but one should try to their best ability to try and include options which are similar. Now, the third thing is, the key is to have only one as the best possible response. So the remaining of them should be inferior or incorrect, or least correct rather. Now that's an example. I know Dr. Nachiket did mention that we are not moving to diagnosis. So in the first 2 years, we're not teaching students how to actually diagnose, but we are getting them towards diagnosis. Now, if you look at this question here, it includes an element of examination as well. So in the current system or curriculum, most of the medical students in the United Kingdom, they learn anatomy and then they are actually moved to performing or apply their anatomy in performing clinical skills. So they do perform clinical skills on each other. So they do what is called as peer examination. So for example, here, they learn the anatomy of the knee joint, and then that's in the dissecting room. It could be a seminar session. It could be a lecture session. And then they move on to performing this at in probably simultaneously soon after, depending on the timetable of the session, or it could follow on from it, where students actually perform clinical skills. So they perform examination of the knee joint. So for the joints, we do look, feel, move, and special tests. So look is similar to inspection, where they inspect the joint. So they look at it, and then they then move on to palpation, which is feeling. And if you think of the anatomical constructs that students can apply there, it is surface landmarks. So they're palpating the bones, the joint line, for any tenderness or pain. And then they actually get the students that they are examining to move the joint, or they try and move it. So there's passive and active movements, flexion and extension of the joint. And they also perform special tests to check the integrity of the ligaments. So in a way, it is good that they are doing these skills earlier on, because appreciation of normalcy is very important for them to be able to pick up abnormality when they move on to clinical rotations. So when they're testing on each other, they know how tight the movement needs to be. They do what is called as an anterior draw sign, posterior draw sign, to examine anterior and posterior cruciate ligaments. So then they watch videos of the abnormal patients where there is so much laxity of the knee if there is an anterior cruciate ligament injury. So this is something that they are taught, and we would include that in the assessment. So if you look at the stem here, it says it's a young female, 22 years old, who was involved in some kind of a trauma when they were playing rugby. So she felt a pop, so some kind of a giveaway sensation, and was unable to continue the match. So it was quite severe. And noticing a swelling, so indirectly giving a hint to the student that there is blood supply to the cruciate ligament, which has ruptured. That's causing increased in the fluid accumulation, leading on to swelling. And then there is laxity, because they've already performed clinical skills. They need to be able to correlate this. And then moving on to diagnosis. So we are not expecting them to be able to diagnose all of it, but some areas like this where they are taught, if it's a ligament injury, they should be able to diagnose it with clinical findings and the history. So we are encouraging them to be clinicians, starting to be clinicians at this stage. Now, a few tips for writing SPA. It should pose a clear question, assess application of knowledge and not factual recall. It should focus on important concepts. And what we definitely practice is that it should pass the cover-up test. What do I mean by cover-up test is when you're reviewing the questions as a group, you would want to try and cover the options, read the question and see if it is possible for you to arrive at an answer. So that's a good SPA. And all incorrect options should be homogeneous. So if you're asking something about an artery, you don't want to include a nerve or a vein in it. So the stem should not be negatively phrased. We tend to avoid phrases such as except or not in the question. So these are often unfocused and heterogeneous options. Now, there are some design flaws in medical education, which is test wiseness and irrelevance difficulty. So we tend to avoid them. Now, test wiseness relates to the possibility of a student who does not know the material, but still will be able to answer the correct answer. So grammatical cues would help them sometime. And a lot of times when we are writing these questions, we tend to have a long correct answer. And students will, if they don't know the answer, sometimes they'll go for the longest answer. We should be also carefully scrutinizing that there are no words which are included in the stem used in the correct answer. This is something what a student who's not prepared could be able to easily pick that up. Moving on to irrelevancy and difficulty. So these relate to the possibility of a student who knows the material, but will be unable to select the correct answer. So the options can be long, complicated, or double negatives. So these are something we tend to avoid. We avoid vague terms such as rarely, usually, none of the above, which is used as an option. And we also avoid stems which are a bit tricky or unnecessarily complicated. Now, for consistency, we tend to avoid names. Instead, we use age and gender for all questions. And we write a question in the third person. And it is good practice to have options arranged in alphabetical order. So this gives an acceptable randomness in medical MCQs or SBAs or extended matching items, which are EMIs. So moving on to extended matching items. Now this requires a theme. So you generally have a theme. It could be a complaint, a setting, a diagnosis, a treatment, and then there is a lead-in statement. So what do you want the students to actually answer? Followed by item stems or vignettes, clinical vignettes or case scenarios. And it is similar to MCQ style vignettes. So you could have 5 stems together in an EMI. So that's usually the standard practice. And the option list this time can have more than 8 options, but 8 is regarded as sufficient for an extended matching item. So you're basically matching your options to the stems. Now, I would like to stress regarding the review process. It's already been mentioned by Dr. Dipti as well as Dr. Nachiket about training the staff. So it is very important that the staff who are writing questions are well trained. So there is some consistency in writing questions and the process of writing them. Now, whether written as a team or if they are planning to write them individually, they need to get together and there has to be a review system where each question is scrutinized by the committee. We tend to include everyone that's available in the review committee. So for anatomy, you would want to include all anatomists probably, and there has to be senior members of anatomy who are well versed with a particular style of writing questions, a particular mode of writing questions. And then the students sit the exam, following which there is analysis of question performance data. Now, psychometrics itself can take a long time, but we tend to use what is called a speedwell. Again, technology has massively influenced in the way we assess, we teach, as well as how we analyze the question performance data. So we have 350 plus students And if we were to sit down and mark them in hand, all the 200 questions that we want them to be tested on, it would be highly impossible, or highly difficult rather than impossible. That's a better way of expressing it. So a quick guide to check questions would be a facility. So you are assessing the difficulty, that is the fraction of the whole class getting a particular question correct. And the value for the good question is between 0.45 to 0.75. And then we also look at point by serial, which is how well the performance of the question correlates to the performance of the whole exam for any given student. So 1 is perfect correlation, 0 is again no correlation. Ideally, it should be above 0.3. And if there is any negative correlation, that is top performing students getting it wrong, we tend to not use the question. So what happens is the questions are then sent back to the author and sometimes the review team to look at the question and see, is that actually appropriate? Because sometimes, especially if majority of the students are getting a question wrong, you would want to actually look at the question, how it's constructed. Does it have more than one answer? And you will be surprised sometimes how often we find that there could be some kind of a problem, but unless you look at the question, the committee has to look at it. And most of the times the questions are written correctly. Can you all hear me? It says my internet connection is unstable. Are you able to hear me?
We are able to hear Dr. Meenakshi.
Okay, thank you. Thank you, Dr. Pushpa. So yeah, we need to analyze the performance data. Now, once we know the questions are good, then they go into a bank of questions. So we tend to use, for every assessment, we tend to use a proportion of newly written questions. Although we have loads of questions in the bank, we still want new questions for the students. Marking, again, can be done for a summative exams either by hand. Previously, we used to use objective marking by optical character recognition. So students need to get a pencil and eraser to their exams, and they're shading which option, if it's an SBA or an EMI. Now, Speedwell optical marker reader does not only the marking, but also does psychometrics as well for us. So all the basic stats. Now moving on to formative exams. Students prefer an immediate feedback, which sometimes is not always possible, but again, technology comes into hand. Now during a lecture, we use what is called as an audience response system. OMBIA is something that we use. There are many in the market that you could use, and it would be good to have one system within the medical school that everybody could use and the students are familiar with it. For example, Zoom. Students are now familiar with Zoom polling during teaching, and we could actually use the audio response system as well when you do the Zoom. Now, virtual learning environment tutorials or virtual learning environment is encouraged, where students have a platform within which you can create tutorials for helping them to have self-directed learning. And again, formative questions could be part of this. So you could use videos, you could use written scripts, name it, and you could add it to it. And especially now with COVID, we have found these tutorials very helpful. It gives one platform where students actually go in, they know what to do, what are the starts with the learning outcomes, whatever we record, recordings go into that, and we can also ensure that they have all these teaching or learning methods in an order. So for example, to perform clinical skills, they need to do anatomy. So you want anatomy to be scheduled first before the clinical skills sessions in the timetable, following which students also have clinical reasoning. So the way case-based curriculum works is students have a case release by a clinician usually, and the case lead, where it's a paper written case which incorporates huge constructs with basic science as well as clinical science integrated in it. So I, as an anatomist, when I am teaching, I always link to that case. Now, although I say a case, now, for example, a trauma case that I lead you could have multiple cases. So if I'm doing a knee joint, the knee joint case could be a separate case written. And it starts from how the patient comes into the accident and emergency department here in the UK, and how the ATLS is actually, that's more clinical, but it's providing context to the students, how they are assessed, how the trauma is assessed in the hospital. And so they have these A, B, C, D, E's that they have to look at in the trauma case. So all this will be in the case release. So when I'm doing anatomy, I will connect how the patient came and what was the history, and then how is that relevant to today's session. So that's already linked to, we do not have to generate a new case for every teaching session. And as rightly pointed, not everything can be tested or taught as a clinical skill in anatomy as well. So we could then go on to incorporate inline questions in the tutorials where students are able to answer a few other clinically relevant questions. So yes, any kind of learning environment is actually useful. Now we do have case release, which is at the end of the case, where there can be patient interaction to sum it up and to look at it from a patient perspective. Now, patients can be brought in during the start, which is the case release, as well as the case roundup to finally summarize. So at that point, you are trying to analyze how actually anatomy is applied clinically, as well as get the socio-cultural context of the patient as well. And because it's all inline, we don't usually now use, because of COVID situations, put such videos, as rightly pointed by Dr. Deepti, because it's going to be a learning environment and students, although having said it is very professional for them not to use, they might still be able to use those videos elsewhere. So we tend to avoid recording. So students have to be present in person for seeing the interaction of a clinician or a teaching staff with the patient actually, and which has been very challenging in these COVID times. So there can be, the next point coming to formative tests, you could have a separate formative test. You could include clinically contextualized spotters. So what we tend to use is they go into the dissecting room, they learn. We do not have cadaveric dissection. We use prosected specimens. But some medical schools in the UK still carry on doing cadaveric dissections. But I think most of us have moved on from cadaveric dissections to demonstration of prosected materials because of the time constraints. Now, the next bit would be short answer questions. This assesses high order reasoning, allows some degree of free responses. So you would want students to talk or write about the anatomical basis. You want them to answer questions as to why and how. For that, we use short answer questions. Now, the literature and the general belief is that it can be unreliable because there is some objectivity in it when staff actually mark these questions. So staff are encouraged to have precise model answers. So it can be a grouped question. This is what we use here at Newcastle University. We use a grouped question comprising of a stem, a vignette, or vignette is a case scenario, followed by one or more sub-questions that are assigned to specific marks. And each of these sub-questions actually relate to one specific learning outcome. And the marks are awarded in such a way that each mark is awarded to a specific point of information that the students are due to write. So if there are 4 arteries that you want to list them, for example, in the sub-question, and you actually want them to write any of the 4, 2 of any of the 4, then you would mention 2 marks. So students actually know that they need to write any 2. So it may not be necessary that you explicitly mention, but I think students need to be told that information. Now that's an example where we've used an image. Now students apply anatomy in imaging when they move on to clinical rotations. So that's an area we use a lot in assessment as well as in teaching. And you can see how there are many sub-questions and each of it has specific marks. So students are able to understand how they have to write, and even for markers, they know how to mark. So there is consistency in marking. No student is disadvantaged. So extended writing question, essays, research products, case presentations, they test higher order organizational and written skills. They're very valid, but for them to be reliable, they need to have great descriptors or anchor statements to score them objectively. Essays, questions which require comparison or synthesis of information are recommended as good practice. Now, we needed to provide a take-home examination for students in COVID situations. And as compared to MCQs, which we do for medical students don't have essays in their assessments. But when I have assessed biomedical students who actually have essays as part of their examinations, this is my personal opinion, I realized essay questions were better for a take-home exam because we could ask a lot about comparison and synthesis and how they're actually, it also takes into account the written skills, how they all put it together within the given word limit. And when I looked at their marks and compared it to the previous years, they seem to be similar, whereas MCQs and SPAs, students score very highly on those exams. Now moving on to assessing skills from knowledge. It's objective structured clinical examination. So there are multiple stations, usually 8 to 10 are recommended as good practice for calculating or for standard setting, calculating the pass score of standard setting. So objective, again, all candidates are presented with the same test. The marking scheme would be the same, well structured. Structured, specific skill modalities are tested at each station. Clinical examinations are where students actually demonstrate and perform the skill. So you're testing their applicability, but also clinical and communication skills, along with professionalism. It's also their professional approach. So it's very similar to what Dr. Dipti showed in a video, where a student is actually performing a clinical skills examination on a patient. Now, we tend to use simulated patients. So we have a bank of volunteers who are willing to come and act as patients when we are examining them in OSCE. So it is very important to instruct them as to what you're expecting from them during these stations. Again, it will be high stake for students. It is timed and they move from one station to another. We usually have 6 minutes for each station. And again, it is, we do not have any specific marks for anatomy. Because we teach a case-based, a very integrated way, we also assess in an integrated way. So MCQ or EMI or any kind of short answer questions for students are not anatomy specific. We don't have a separate anatomy. Now, similarly, OSCE would be an integrated knowledge of all anatomy, physiology, and other bits that they are trying to apply to it. So there is no, as an examiner, I wouldn't be asking them any questions. It is all about them performing. So I would just stand and watch, and the students are expected to speak out as they move from one to another. As you saw in the video, they usually talk through to us as to what they are doing. So if they are looking for a PEX beat and they keep their hand or the palpating finger on the second intercostal space, as an examiner, I know that's not where the apex beat is felt, because I know it's in the fifth intercostal space, and that's how we connect anatomy to the clinical skills for the students. Now, OSPE, again, some of the universities do that. We did do spotter examinations previously, but I think this is very apt for programs which have a horizontal integration. I know when I was doing my post-graduation at St. John's, we used to have a session where, as Dr. Nachiket described, where there was horizontal integration, where anatomists, biochemists, and physiologists came together, and they helped students to be able to apply all this knowledge to a clinical scenario. So this can be practically tested, and you're relating identification of structures on cadaveric prosections or models to clinical laboratory data, clinical and laboratory data, and could incorporate images as well. So as you can see here, this is an example similar to either, I can't remember either to Dr. Nachiket or Dr. Dipti, whoever mentioned about a heart scenario, where you tend to give a case scenario there, and which clearly mentions what's happening. They performed an ECG and they've diagnosed myocardial infarction. So they have to relate the physiology bit to the anatomy. So they could use, or we could use cadaveric specimens, or we could use models here. And as you can see, these are labeled, the arteries or the vessels are labeled, and the question clearly asks or relates to this label here and the myocardial infarction. So they have to interpret the ECG. So they're applying their knowledge and integrating their information. So for a given clinical scenario, students are asked to label. They are asked to interpret given a physiological or a pathological laboratory data or clinical situations. You could use a radiological image as informed previously. Anatomy spotter examination is one of the things we used to run previously, but again, due to practical reasons, we have moved on to incorporating such questions in the written exam. You can see how students need to actually identify the label structure. So that's knowledge recall, but then they can be connected to the clinical implications of this. So which movement is affected if injured? So you're talking about an injury, but you're asking them what movement is it supposed to be doing. So that's quadriceps muscle. It is supposed to cause extension of the knee. That's the movement we talk about. But students will have to try and apply their anatomy knowledge, identify the muscle and identify that's the ligament for the muscle. So what action will this have on the joint is what they need to be able to recall. So there can be an element of clinical vignettes or scenarios or implications that we could use. And one of the research study that I was involved in when we had the spotter tests was we found that the clinical vignettes actually improved performance in anatomy practical assessment. And if we use this as formative, as you can see, I've incorporated this in a 2-dimensional rather than 3-dimensional cadaveric prosected specimen. So this can be used formatively as well to students to encourage to be able to think. And textbooks like Student Grace Anatomy, Moore and Daly, they have, at the end of the chapters, they do have clinical implications already there. So it's useful to be able to use those textbook case scenarios because you would reckon that students would actually be studying those textbooks, would be looking at those case scenarios. However, technology has improved so much now is Medical Elsevier. They have online textbooks, they have online cadaveric videos, and I'm very pleased to say that the university has secured funding for that, where students are given online access, and it has been so useful, especially with the COVID situation currently. Now, challenges for running any skill or written exams is feasibility issues. So time is important. Staffing, do we have enough number of staff that we could manage? Resources, again, financial implications. Do we have space? Now, clinical skills is performed in a clinical skills lab, which is kind of a space where ward settings with bed and necessary equipments are provided to the students. So they're examined in those places, taught and examined in those places. Then using simulators, whether it's patient simulators or the machine simulators that we use. So it is important to consider these kind of resources. Again, item, so we're looking at staff writing the item, what available resources do we have to write a question, how do we construct, how do we build a bank of questions, how do we mark? So it's all challenging to put it all in a nutshell. Now, standard setting is a process by which we calculate a pass score. Now, there is norm referencing, which is based on how an examinee performs against a reference population. Now, many institutions have traditionally chosen an arbitrary pass score, which is usually 50%. This is in the United Kingdom that I'm speaking about. And more of an approach that is followed on from year after year. We still do that for biomedical science students or any other healthcare professional students. But we have now moved on to what is called as a more modern approach, which is criterion referencing. Now, this is based on some absolute standard of knowledge or performance. So we tend to determine pass score more precisely. So if you consider the criterion reference methods, it is either examinee-centered, borderline regression is what we tend to use for OSCE. Now it can be test-centered, Angoff method is what I'm going to show you an example of how to calculate or how to standard set using Angoff method. So, or EBEL, universities use this for OSPE examinations. Now this is with reference to what learned think. So now before we go on to how staff actually are involved in standard setting, I would just like to give you all a few seconds to probably kind of think about borderline students. So what do we mean by borderline students? These are students who are on the fence. They can go either way. They can either pass or they can either fail. So what do you think will be their characteristics? So this is very important for standard setting in Angoffing method. So just a few seconds, when you think of borderline students, who are the students you're thinking of? Okay, I'm sure you've had at least one thought, but some of the thoughts here, they are hesitant students who have had a superficial knowledge. They've not learned material in depth. Now, these are students who are quite unprepared. They have patchy knowledge. They've studied some areas, but not all. That's required for them to be competent practitioners. They are unable to explain certain areas. They kind of lack empathy when they're talking to students, when they're performing clinical examinations. And they can be rote learners. So when we give application of knowledge like SBAs, they might not be able to apply their knowledge well. Now, this is an example of standard setting. So these are the MCQ, the left first column has all the MCQs listed here. And then these are the staff who act as judges. So the recommendation is around 8 is good practice. And you can see that's the maximum that they've scored and that's the minimum that they've scored. Now they usually score each of this independently, or we could do it collectively as a group, but their scores are individually given. And then when we look at the difference, now if there is 40% or more difference, then we usually ask them to meet and we kind of moderate their judgments. So what are they actually trying to do in those? How do they get this percentage mark? How are they scoring them? So they look at a question and then they think of a borderline student and they think of what proportion of borderline students would get this question correct. So that's what proportion of borderline students would get this correct. Now, if you see this, the fifth item here, so the judge one says it's 0.6, so that's 60% of borderline students. So they've scored it as 60% of borderline students should get this question correct. Now, when you actually look at the maximum and minimum scores, there's a difference of more than 40%. So you would want the person who scored as 80%. So in my experience, if I have taught a session, I think I usually go for higher scores because I've taught a session. So it's good to include those who have actually not taught a session. So you tend to have an overview of the scores. So if there's more, then you have conversation and you moderate those conversation as the lead. So there has to be a lead who does all this. So you have to have a lead or a chairperson. And during moderation, you can see the basis as to why they have given low and the other person has given high. And most of the times, the person who scored low, very high usually comes down a bit, or the person who scored very low kind of moves up, and we usually get around maximum 40% difference in each of their scores. So how do we calculate a cut score or a pass score? So if you look here, each of these rows is indicating the last column is the judge's mean. So you take the mean of all these judges' scores, and then the cut score is again the average, then the mean of this, or the average of this is giving you a cut score. So this is usually around 50%, to be quite precise. So it's usually more or less than 50%. And this may vary between different exams. It depends on what questions you kind of choose. And when you choose questions as well, you've got the database which actually tells you which are more discriminatory questions. So you would want to have an exam paper where most of the questions the average students can answer, but then you want them to be discriminatory. So you would want to include questions which only merit students are able to answer. And some you want to have easy questions as well. So it has to be a mixture of the questions. Now, lastly, it's the context. I think all of us have stressed more than enough about the context in which medical students learn. So the main focus of medical education is to produce competent doctors who are able to perform clinical practice safely and effectively. Now, Gordon and Badley, a psychologist who conducted an experiment in 1975, published in, his work has been published in the British Journal of Psychologists, where he made divers learn learn a set of words in two environments, one on dry land and one underwater. Now, the lists which were learnt underwater were best recalled underwater and vice versa. So, again, there's a lot of research and literature which is suggesting that students learning in a particular context, that's classroom setting, when they move on to clinical rotation, they find the transition very stressful because it's a completely different context where they are now applying knowledge. So to ease the transition, I have been fortunate enough to have conducted some studies where I have involved clinicians, their opinions obtain their opinions as to what they value as most clinically relevant anatomy components for teaching students. And at the end of the anatomy teaching, getting them involved, like a seminar sessions where they come in and interact with the students rather than one clinician coming with their own concept. There was a group of clinicians who actually came in and taught students, and students valued these sessions very highly, because I think the fact is some of us are not medically qualified, and most of us who are medically qualified and who are into academia have not had the experience of going into the clinical world, and medicine progresses very vastly. And even though we've had some clinical exposure, it's in a particular speciality that we would have had. So it is what we thought was it would be important for us to obtain what each speciality, from each speciality, what they thought was to benchmark those clinical conditions or applied clinical aspects, what each specialty thought. So the one which is published is what on the orthopedic aspects. So we've also conducted obstetrics and gynecology study, and there is many more planned. What we are trying to gather is information as to what is, we can't teach all of the clinical scenarios, and students learn anatomy, which is a factual subject. I mean, they have to know their anatomical facts to be able to apply them. So that can't change. So one of the challenges is they are learning a science discipline, and then we are helping them with the clinical contextualization to encourage them to be able to see the relevance of this, how to be able to apply anatomy after they have learned their knowledge. Now, it is very challenging for students because they have limited clinical exposure. They have not met or they have not examined patients. They are examining each other in clinical skills, but it is the clinical exposure which they are lacking. So in our understanding, there has to be a fine balance, and this is my perception as well. So there has to be a fine balance between what factual knowledge they're learning and how much will they be able to learn how to apply. And this has to be incorporated in teaching if you're planning to assess. So, which is what we are incorporating more formatively. So we're using these kind of scenarios or these application clinical situations, what the clinicians say, to incorporate in our
Dr.
lecture.
Meenakshi?
Practicals and
Dr.
yeah.
Meenakshi?
Yes, yes.
How long are you going to take?
The last slide, last few slides.
Yeah, okay, thank you.
I've got a summary slide next in a few more. So effective testing on learning will be repeated testing is useful, effortful recall is essential, and feedback is crucial to learning. Now, experiential learning and assessment is also important. Now, formatively, you can use adjuncts such as ultrasound and DICOM viewers. You can use SimMan or other simulators for integrated knowledge and performing skills. And we have successfully incorporated them in teaching first and second year medical students earlier on with anatomy and clinical skills. To summarize, competency-based medical education necessitates a robust and multifaceted assessment system. Careful planning and design is essential, and this has to align with the learning outcomes and the teaching that you have incorporated in the curriculum. And the sample should be as wide as possible. The assessment viewed as part of education process in authentic contexts is good practice. Any questions? Thank you.
Yes, Meenakshi, in the question answer, there's a question which is raised. Is OSCE preferred for anatomy? Because it's used for clinical testing, is it preferred for anatomy?
Yes, OSCE. OSPE is it, or OSCE, sorry, is it OSCE or OSPE?
OSCE.
OSCE. For anatomy specific, I wouldn't say, if you're not teaching it in a very integrated way, you could have aspects of it. But as a whole examination may be difficult if they are not learning other clinical constructs. But yes, it would be a good start if we would try and incorporate some anatomical aspects into an OSCE, like palpation. I'm sure I've looked at the MCI learning outcomes as well. It does talk about palpating arteries, I guess, if I've not, forgive me if I'm wrong, but I'm sure there was something to do with arteries of the limbs. So we have a station called as examination of peripheral pulses. So now we have a station which is pulse and blood pressure. So when we're doing lower limb examination of pulses, we incorporate that as a station where students actually have some communication skills, like the video shown by Dr. Deepthi. Then we also do upper limb palpation. We could incorporate that with the physiology. So they could actually measure blood pressure on a simulated patient in an OSCE. Yeah, it could be.
One more question is like how to conduct this integrated assessment. How do you plan to conduct this integrated assessment?
How do you plan to conduct? Okay, so I think blueprinting is very important. So you will be having, what I showed you was more for specific for anatomy, but if you have many more subjects like anatomy, physiology, biochemistry, which is what I'm guessing, here we have even more subjects. So we go through the process of blueprinting, and because it's all system-wise, so they learn, if you learn a system, so say for example, if you're learning a cardiovascular system, you learn anatomy, you learn physiology. So you would want to allocate, you'll have to decide what percentage of questions you would want to allocate for anatomy, for physiology. So blueprinting is essential for integrated assessment.
One more question is, what are the suggestions to institutions where we have need to work in a resource limited setting? So how to increase the student faculty ratio? What is your suggestion on this?
I think with the COVID, the positive is we are able to deliver online teaching. The seminar sessions could be smaller, the groups could be smaller, and dividing learning outcomes into self-directed learning as well. So there is an element of self-directed learning before students actually come into the dissection room. So when I was a medical student, I was asked to actually learn anatomy before I come and dissect. I'm sure which is the same even now. So students are having self-directed learning. So dividing the learning outcomes into self-directed learning outcomes and taught learning outcomes will ease the burden on the teaching staff as well. So some of the learning outcomes can be taught in the dissection room. Some of them can be taught in the lectures. We normally tend to discourage a lot of lectures in the curriculum because as it can't be very interactive. In anatomy at times, it's very didactic. So incorporating videos of information where it is very didactic, and then a flipped classroom approach is what I'm talking about. So, and then when students come into the session, you are giving them some information, but making it interactive and reinforcing the information that they would have done as an STL could be a good approach. And what we would encourage is some kind of tying up together, which is one of my research areas that I'm currently doing, is at the end of all the anatomy that they've learned application for each case in a case-based curriculum that we are delivering, I would do a roundup clinical anatomy session where again, we are trying to reinforce all of the anatomy learned in the clinical situation or scenarios with clinical scenarios. So clinical anatomy seminars could be a horizontal integration, like how Dr. Nachiket was mentioning, where you could bring in physiology, you could bring in biochemistry. So it could be either dealt as specifically anatomy, or it could be dealt as a combined seminar session. But I think repeatedly getting them involved and testing them formatively and reinforcing aspects is what would be a good practice.
One more question is, somebody's asked whether region-wise teaching or system-wise teaching is better, which is preferred?
To be honest, in the last 5 years, moving between two universities, one of the universities moved from region-wise to system-wise. And then when we came to Newcastle, it moved from region-wise to a case-based curriculum. To be frank, in my experience, I think whether you teach anatomy in a region or system-wise, it is still, as long as it's clinically contextualized and connected or relevant to either a case or to some kind of clinical situation that they can see very broadly, it would kind of make it more effective. Because anatomy is, whatever you say, it's still region, whether you teach it system-wise or as case-based, or you're still teaching a factual knowledge of that particular region. So I think there's a very thin line whether you teach system, all systems work, to be honest. You can't say one is better than the other, but I think making it the spiral curriculum is what we had previously to case-based, as opposed to case-based curriculum, what we have currently. And it's not much of a difference for anatomy, it's for more broader way. I don't know if I've answered your question, but I think I've tried.
So I think no more questions. We can conclude this. Thank you, Dr. Meenakshi, for taking us through the assessment tools. What are the challenges and how to standard set? I think that is, you've given us the how to think big. So I think we need to move from traditional, we are moving towards CBME. I think we need to think of the standard setting. Thank you, Dr. Meenakshi, for taking us through this and holding all the faculty participant till 1:30 here or 1:45. So thank you all.
Thank you, Dr. Pushpa, for inviting me as well. Thank you very much.
A brief concluding remarks of all the speakers. So first and foremost, Dr. Nachiket Shankar, he spoke on preparation of case scenario in teaching and assessment, the need for using case scenario in anatomy, the role of basic science teachers with the evidence-based literature, and the magnitude of problem with Newton's laws of motion. And he also explained Bloom's taxonomy and gave examples for the case scenario in both teaching practicals as well as theory aspect. And he also told about how to integrate or link the cases, which is most important, and the guidelines for creation of case scenarios, that is 8 tips. Then explained about the spiral curriculum with all the interactive session. Thank you, Nachiket sir. Dr. Deepti Shastri delivered on early clinical exposure. She started with the blackboard drawing and she told about the importance of why ECE, what is ECE, and preclinical experience for removal of the resources as well as elements and net rationale of ECE with the case scenarios for assessment, both for theory and practicals with structured questions. Then examples for the long essay, short essay, and MCQs. In planning for ECE was well explained with humanities and medicine. Thank you, madam. Next, Dr. Meenakshi Swami explained about the assessment tools in details, challenges faced, as well as OSPE in detail about the how to mark the OSPE at your setup. And you also explained the multiple objective measures, characterization of good assessment tools, blueprinting, etc. Thank you for sharing your best practices at your esteemed university, United Kingdom. Thank you, one and all. I thank all the participants for patient hearing. Thank you, one and all.
Dr. Nachiket Shankar and Dr. Deepti ma'am, any comments?
So first of all, I'd like to once again thank the organizers for inviting me for this webinar. And like I said, I learned probably more than the others learned from me. So I think the other two talks by Dr. Deepti and Dr. Meenakshi were really eye-openers for me. And I learned a lot from the Dr. Meenakshi and Dr. Deepti. And it was a great learning experience for me as well. So thank you once again. And I thank the participants as well for that active participation. Thank you.
Dr. Deepti ma'am.
Thank you once again, ma'am, Dr. Pushpalata, for inviting me for this webinar. I would like to thank Dr. Meenakshi Swami. Though I have been familiar with assessment tools in the Indian context, blueprinting also I've been very familiar with, but I learned such a lot from your presentation and what is done in the UK context. I hope we can keep in touch so that we can learn on implementation of CBME more effectively in our setup, like using your UK experiences. Thank you so much, Dr. Meenakshi. I would like to thank Dr. Nachiket. It was very nice to listen to what is the science behind creating case scenarios. So the technique for creating case scenarios and the tips that you gave, they are very effective. And I like the way you conducted the session by involving the participants right through your session. So thank you, both of you, Dr. Meenakshi and Dr. Nachiket, for making me learn new skills. And thank you once again to JSS Medical College for inviting all of us. Thank you.
Thank you, ma'am. Thank all the speakers and the stalwarts in medical education. Thank you, one and all.